Kudus.
Attention, ladies and gentlemen. The opening ceremony of International Webinar Series 2022 on Nursing in the agenda of 24th Anniversary University of Muhammadiyah, Kudus is going to be started. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. Alhamdulillahilladzi an'amana binikmatil imani wal islam. Wa nusalli wa nusallimu ala khairil anam sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in, amma ba'd. Good morning, ladies and gentlemen. Welcome to the International Webinar Series on Nursing in the agenda of 24th Anniversary University of Muhammadiyah, Kudus. The Excellency Rector, University of Muhammadiyah, Kudus, Dr. Rusnoto, Master of Epidemiology. The Honorable all speakers, Professor Wang Hsiu-Ho, Yuanpei University of Medical Technology, Taiwan. Dr. Nguyen Thi Hoa Huyen, Vin University, Vietnam. Dr. Regie Bautista, System Plus College Foundation, Philippines. Mrs. Noor Hidayah, Master of Health, University of Muhammadiyah, Kudus. Mrs. Karyati, Master of Health, Maternity Nursing Specialist, University of Muhammadiyah, Kudus. The Honorable Vice Rector for Administration and Finance, Mr. Rizka Himawan, Master of Psychology. The Honorable Vice Rector for Student Affairs and Cooperation, Mrs. Ani Rosiana Masito, Master of Nursing, Mental Health Nurse Specialist. The Dean and Vice Dean Faculty of Nursing, the Head of Nursing Study Program, Convener Taiwan International Healthcare Training Center, and all participants. In the name of Lord, today we are gathering virtually in our International Webinar Series on Nursing in the agenda of 24th Anniversary University of Muhammadiyah, Kudus. On Saturday, October 29, 2022, ceremony of International Webinar Series on Nursing in the agenda of 24th Anniversary University of Muhammadiyah, Kudus, entitled Reproductive Health, Pregnancy, Problems and Complication Readiness. Let's start this agenda with saying Basmalah together. Bismillahirrahmanirrahim. Singing National Anthem of Indonesia Raya. Welcoming remark from Rector University of Muhammadiyah Kudus to Dr. Rusnoto, Master of Epidemiology. The stage is yours.
Baik, terima kasih. Thank you very much, MC.
Siap.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. Allahumma sholli wa sallim ala sayyidina Muhammadin amma ba'du. Thank you very much for participation webinar international with University of Muhammadiyah Kudus. The honorable all speakers once Prof. Wang, Hsiu-Ho, Yuanpei, University of Medical Technology, Taiwan. Dr. Nguyen Thi Hoa Huyen, Vin University, Vietnam. Dr. Regie Bautista, SPCF, System Plus College Foundation, Philippines. Miss Nurse Noor Hidayah, Master of Health from University of Muhammadiyah Kudus. Miss Sri Karyati, Master of Health, Maternity Nursing Specialist from University of Muhammadiyah Kudus. The Honorable Vice Rector for Administration and Finance, Mr. Rizky Imawan, Master of Psychology. The Honorable Vice Rector for Student Affairs and Cooperation, Ms. Ani Rosiana Masito, Master of Nursing, Mental Health Nursing Specialist, Converter of Taipei Hospital and Taiwan International Healthcare Training Center, and all participants. Here is the 100th participant. Thank you very much. Firstly, let's praise be to Allah Subhanahu wa Ta'ala, the Lord of the words and the sequel. If for those who keep their duty into Him, fathers, there will be no hostility, expect gain, wrongdoers. Secondly, salawat and salam for Muhammad Rasulullah Sallallahu Alaihi Wasallam, his family, all his disciples, and those who follow them in goodness till the day of judgment. In this very specialist occasion, I am pleased to welcome you the international webinar series on nursing entitled held by Muhammadiyah University of Kudus in collaboration with the ISTC Taiwan. Ladies and gentlemen, issue of pregnancy problem are an issue of fundamental human right, maternity, mental well-being is an essential component in the healthy development of our families and communities, and this fact must be recognized and promoted to ensure healthy life for all the citizens of the Master Island. Saving this objective in the health of sustainable development goal number 3 as part of the United Nations Agenda 2030. The agenda provides all of our country with a practical action plan for the sustainable future of our world. It takes global goal and proposed ways is one of use. As individual and as communities can take action to improve the well-being of our societies. Women and families deserve to be supported in a variety of ways, especially when issues of mental health as a result of a pregnancy become a cause of concerns. According to indicators from the World Health Organization, about 10% of all pregnant women and 13% of women who have just given birth experience mental disorders, particularly depression. One of the University of Muhammadiyah Kudus version in being global, This international conference is one among many efforts to make this vision come true. I believe that we participate in the international webinar. We are in the right place and the right time. Together, let us accelerate the exchange of ideas and scaling up of good practice in nursing field. And I wish you all a very successful webinar. I'm sorry, here I in Surabaya to conference Rector Forum in Indonesia. So I very much for your participant and speaker in this morning. Thank you. I declare that this international webinar is official open. Thank you very much for your attention, and I look forward to exploring the top of your deliberation. Thank you very much for participation, and I close. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much to Dr. Rusnoto, Master of Epidemiology. Ladies and gentlemen, those are the opening of International Webinar Series on Nursing at the University of Muhammadiyah, Kudus. That's all from me as Master of Ceremony. Let's close with saying Hamdalah together. Alhamdulillah, Hirabbil Alamin. Billahi fi sabil haq fastabiqul khairat. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
The next photo session.
Going to have a photo session together. Now, please, I invite to the Rector and Vice Rector of Muhammadiyah University of Kudus to join the photo session, please. Rector and Vice Rector. Okay. Please, the Rector and Vice Rector, be ready for the photo session together. Okay, now we have a photo session together. I invite to Rector of the University and also Vice Rector to join the photo session together first. Okay. One, two, three. Again. Again. One, two, three. Smile. And then now. Freestyle. Okay. So thank you very much for the photo.
Ladies and gentlemen, now we come to the main agenda of International Webinar Series on Nursing in the agenda of 24th Anniversary University of Muhammadiyah Kudus, entitled Reproductive Health, Pregnancy, Problems and Complication Readiness. This will be guided by Mr. Ahmad Nur Syafiq, Master of Education, as moderator. The stage is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Innal hamdalillah nahmaduhu wa nasta'inuhu wa nastaghfiruh wa na'udzu billahi min shururi anfusina wa sayyiati a'malina may yahdihillahu fala mudhillalah wa may yudlilhu fala hadiyalah. Asyhadu an la ilaha illallah wahdahu la syarikalah wa asyhadu anna Muhammadan abduhu wa rasuluh la nabiyya wa la rasula ba'dah amma ba'd. Well, ladies and gentlemen, welcome to the first international webinar series on nursing. Today's topic will be reproductive health, pregnancy, problem, and compliance readiness. So, in this webinar series, we are going to talk deeply about the pregnancy. And, well, ladies and gentlemen, as we know, today every single country has a problem itself or its own about the pregnancy. Even every single research has been done to cure or to complete the side effect of the pregnancy happening. And today we have amazing speaker who will talk about this topic in a very detail. Well, before the presentation is done, so I would like to say thank you first to the convener of Taiwan International Healthcare Training Center who always support and collaborate for our international webinar in every single year. And before we go further, so I'd like to say thank you very much to all speakers today, Professor Wang, Hsiu-Ho, Dr. Nguyen Thi Hoa, and Dr. Regie Bautista, Mrs. Noor Hidayah, Mrs. Karyati, and another speaker. Right, so to save our time now, let's go directly to the first presentation from Professor Wang Hsiu-Ho from College of Medical Technology and Nursing, Yuanpei University of Medical Technology, Taiwan. Today, Professor Wang Hsiu-Ho will talk about the use of alternative and complementary therapies during pregnancy and childbirth. Right, before the presentation, so let me keep in touch first with the professor. Okay. Right then, so let me keep in touch with the first speaker, Professor Wang Hsiu-Ho. Have you been connected with us? So we are still waiting for the connection from Professor Wang Hsiu-Ho. Hello, Professor. Have you been connected with us?
Yeah, we are here from the University of Medical Technology with the professor.
Okay, so hello, Professor. How are you today? Good morning, Professor.
王 Sir 他们现在有问题就先去选那边。
Did you hear my voice?
Okay, I
Professor?
will.
Okay, so it seems that now we are connecting with the Professor Wang. And today, once again, she will talk about the use of alternative and complementary therapies during pregnancy and childbirth. Before the presentations, let me read first her key activity for a while. So, Professor Wang has 26 years of teaching experience, mainly teaching obstetric and gynecology nursing, women's health, nursing research, alternative therapy, and etc. So, Professor now is the assistant of professor at Yuanpei University of Medical Technology, and also nursing supervisor at Martin de Forest Hospital, and also nurse at Taichung Veterans Memorial Hospital, and nurse in Taipei Veteran Hospital. Later on, some research has been done by Professor Wang, include the different effect of age on quality of sleep and depressions in patients receiving maintenance hemodialysis, and also she has another research entitled 6 questions regarding mobility in the World Health Organization Quality of Life questionnaire predict 3-year mortality in patients receiving chronic hemodialysis. Right, to save all times, now let's go directly to the first presentation from Professor Wang. Right, so Professor, now the stage is yours.
Good morning, everyone. Today I will present my topic, the use of alternative and complementary therapy during pregnancy and childbirth. What is the complementary and alternative therapy? CAM has traditionally been defined as a group of diverse medical and healthcare system practice and products that are not generally considered part of conventional medicine. More and more people are turning to alternative medicine and therapy these days because of its popularity and numerous health benefits. Many conditions and diseases which are not easy treated with conventional medicine or are too costly have better and cheaper alternative. Also, many people believe that nature is healthy and turn to practice like yoga therapy and acupuncture for treating the disease. Then option to use chemical-based drugs. Complementary medicine encompasses approaches used in conjunction with conventional medicine, while alternative medicine encompasses approaches used in lieu of conventional medicine. More recently, the National Center on Complementary and Integrative Health, NCCIH, has moved to using the broader term complementary health approaches, since most people who use can do so in addition to conventional treatments. It encompasses a wide range of therapy that can be divided into 5 categories: alternative medicine practice, traditional Chinese medicine, acupuncture, homeopathy, etc., mind-body intervention, mediation, yoga, imaging, prayer, etc. Biological-based therapy, herbal medicine or teas, dietary supplements, or Epid, etc. Manipulative and body-based methods, osteopathy and chiropractic manipulation massage therapy, and energy healer therapy, Qigong, Tai Chi, Reiki, etc. This therapy can be used either alongside conventional medicine, complementary medicine, or by themselves, alternative medicine. With such a wide range of therapy considered to be can, it's important to note that different type and category of can have different risk profiles and can have a wide range of implications for the health of the mother and the fetus. This picture shows complementary alternative medicine can. The top 10 complementary alternative medicine therapy: yoga therapy, acupuncture, Ayurveda medicine, homeopathy, hypnosis, massage therapy, mediation, Reiki, diet therapy, aroma therapy. And this picture shows the 5 domains of complementary alternative medicine. Can widely consist into 5 categories. Mind and body medicine, for example, mediation, manipulative body-based practice, example, osteopathy, whole medical system, for example, homeopathy, biological-based practice, for example, diet therapy, energy healing therapy, for example, Reiki. And this picture shows the alternative medicine. It contains biological-based practice, manipulation, and body-based practice, energy healing, whole medical system, and mind-body therapy. The use of the complementary and alternative medicine during pregnancy. In light of the stringent evidence for subsequent use can by pregnant women and the concerned race for the safety of can, a closer examination of the prepartum outcomes associated with the use of can during pregnancy is needed. Understand pattern of can used during pregnancy can also have implications for healthcare costs. And this is a case of yoga, massage, chiropractic, acupuncture, acupressure, relation techniques, e.g. hypotherapy and mediation, and aromatherapy still benefits from very level of empirical examination, despite the lack of definitive effectiveness research. The use of can during pregnancy and postpartum is clinically relevant. For example, no harmful effects have been linked to mind-body can interventions such as yoga, hypotherapy, and imaging, and it would be unlikely to encounter an adverse effects from prayer or energy healing when used in concert with conventional medicine. So biological-based therapy, the use of biologic-based therapy such as raspberry tea leaf and some herbal and vitamin supplements during pregnancy has been associated with adverse events, such as premature closure of the ducts uterus and neonatal hyponatric seizure, while the use of other supplements such as prenatal vitamin has been widely accepted by the field. And the prenatal symptom and the condition, recent evidence suggests there has been growth in camp approaches for non-medical management of various prenatal symptoms and conditions, including non-pharmacologic alternative for nausea, vomiting, pain management, or labor induction. And CAN therapy during pregnancy. Certain CAN therapy has been demonstrated to be effective during pregnancy, including ginger for nausea, vomiting, omega-3 fatty acid, and folate for prenatal depression, and prenatal yoga for depression or for reducing stress and increasing comfort during labor. And using CAN therapy for pregnancy, women are also using CAN therapy that may be contraindicated for pregnancy, especially if used in conjunction with conventional medicine. And the ginger is an ancient herb used widely in history for its many natural medical properties and particularly as an antiemetic. The best available evidence demonstrates that ginger is an effective and inexpensive treatment for nausea and vomiting, and is safe. Relieve stress and complaints. Several studies have reported the use CAN among pregnancy women for relief of stress and pregnancy-related complaints, preparation for labor, and for general health benefits during pregnancy. 2 studies them CAN use specifically for nausea and low back pain during pregnancy. This table shows complementary and alternative medicine modalities surveyed in National Health Interview Survey. CAN category, biological therapy, and mind-body therapy. Individual CAN modulated diets, dietary support, and biofeedback, deep breathing exercise, hypnosis, guided image mediation, and Qigong Tai Chi support group yoga. National Health Interview Survey data are from the 27 National Health Interview Survey, NHIS, examined a national representative sample of United States women aged from 18 to 44. Primary outcomes were past year CAN use, reason for CAN use and the condition, treat with CAN pregnancy status. And the outcome, overall, 67% of reported age United States women reported using any CAN in the past year, excluding vitamin. 42% report using CAN. Significant difference in use biologic base, and the mind-body therapy by pregnancy status were from back pain, neck pain, and anxiety were the most company report condition treated with scan among the reproductive age women. And however, 20% of pregnant and postpartum women use CAM for pregnancy-related reasons, making pregnancy the most common reason for CAM use among the pregnant and postpartum women. And the table showed the pattern of consultation with the convention of CAM practitioner for pregnancy-related condition. The woman consult a wide range health care professional for a variety condition and or symptom. See table. The most prevalent condition reported was back pain, and which the woman most commonly consult with calculators, followed by obstetrician and GP. May fail. Those women reported tiredness. And this picture shows type of CAM. Women report that disclose supplement used to other obstetrical providers most frequency. 94% prior use was one of the CAM therapy of which providers were less likely to be aware. The provider reason to CAM use discourse was perceived by women as positive or nature over 98% of the time. And this picture shows type of CAM use. Spiritual healing 65% and the herbal supplements 51% were found to be common type of CAM therapy used throughout pregnancy in the present survey, as it is totally in figure. And the picture shows the most frequency concerned herbal supplement were ginger, garlic, and DMX. And the table showed use of complementary and alternative medicine in pregnancy. A cross-section survey on 11 women. Reason for using CAM and the CAM certification are shown in table. About 43% of the CAM user considered that it was not dangerous for their pregnancy, and 28% used for its effectiveness. And then the picture shows the frequency of CAM use study participants in total. 36% use CAM twice a week, and 35% sometimes, and 18% daily, and 9% had used only once. And this table shows complementary alternative medicine used among postpartum mother in a primary care setting, a cross-section study in Malaysia. Table shows the different type of CAM utilized by postpartum mother who attempt to attend the clinic. The most common type of can use was menopause body therapy, followed by biological-based therapy. In the study, we found that neonatal and the outcome associated with can use during pregnancy, labor, and birth. The current literature examining the role of acupuncture, acupressure, and the other related treatments for pregnancy, labor, and birth include 2 systematic review and 7 additional original research articles. Research exam outcomes related to use of acupuncture and acupressure by women during pregnancy, labor, and birth was reviewed in a paper published by the Cochrane Corporation in 2011. This meta-analysis included 13 trials of pregnant women and focused primarily on the use of acupuncture or acupressure for pain management in labor. And the reviewers reported that women use acupuncture experience less intense pain compared with no pain management technique. With some indication, acupuncture may also reduce the likelihood of pharmacological anesthesia when compared with the placebo controlled or standard care. The reviewers also identified fewer instrument delivery for women use acupuncture during birth. And the yoga mediation practice. Research examined birth outcomes associated with yoga and the mediation practice during pregnancy has been summarized in 2 reviews in recent years and further developed through 3 additional original research articles, of which the principal focus has been yoga with mediation, include primarily as an aspect of yoga practice. The intervention group developed a significant less complications such as pre-eclampsia, gestational hypotension, gestational diabetes, and intrauterine growth restriction. There was also an improved outcome for babies with fewer infant born small for gestational age, birth or with low upper score in the yoga group. And the massage therapy, the outcomes of massage for pregnant women has been reviewed very recently in the contents of its effects on pain management in labor, and very little additional research since this review has been conducted. A Cochrane review of the topic identified 6 trials of massage for labor pain management. The use of massage was found the result in women reporting less pain during labor and the reduction anxiety during the first stage of labor. And this study identified the massage group had a lower subject pain score, but those with constant birth attendance with lower anxiety labor satisfaction was higher across the entire birth experience. For the women received the massage, intervention, and the duration of stage 1 of labor was reduced for these women. This study found ice massage to provide the most persistent pain relief compared with the other two groups. An analysis of cross-sectional survey data involving women who had recently given birth has also examined the outcomes of massage during pregnancy on birth outcomes and found insignificant difference on any report outcomes. And aromatherapy. There have been some attempts to examine the outcome associated with the use of aromatherapy during PLV in recent years. A systematic review of RCTs examined the effects of aromatherapy in the measurement of labor pain. The review included 2 studies and report no difference in a range of parameters, include pain intensity, cesarean vaginal birth, cesarean section, administration of 2 special care nursery, use PPMT, spontaneous vaginal delivery. The review included 2 studies and report no difference in range of parameters, include pain intensity, position, vaginal birth, sterilization, acupressure point. 3 acupressure points were used, namely GB 2021, LI4, and SP6 as indicated. GB21 is one gallbladder mirror and located at the Three acupressure points were used, namely GB21, LI4, and SP6, as indicated. GB21 is on the gallbladder mirror and located at the highest point of the shoulder, which was defined as the midpoint of a line between the 7 cervical vertebrae, the latter extremity of the acromion. LI4 on the large intensity membrane and local at the back of the hand between the thumb and the forefinger in the middle of the second metacarpal bone radially. SP6 is on the spine median located 3 cm above the medial meniscus of the ankles. Reference was carried out next on the pituitary zone. And the refractory on the big toe of both feet, front plus like pressure was applied 30 times to each big toe reflex zone and to each acupressure point, which was for a complementary 30 each or as long as the woman can tolerate. And the aromatherapy is currently the most common used complementary therapy despite the minimal evidence which is regard its use. Chen et al. And Burns et al. Demonstrate that is many have positive effects in labor. Aromatherapy was a 10-minute session of aromatherapy was included in the study. This was carried out using a specific combination of oil which was made by them to support a complementary post-state remain which incorporate 3% blend of the essential oil, lavender, carrot, sage, and jasmine mixed within a base carrier oil, such as grape, and i.e. 1 drop of each essential oil in 5 ml of grape. And locally Midwest trained an aromatherapy tried 3% blend containing 60 ml of grape oil with 12 drops each of jasmine, lavender, and clear sage. The blend oil was used to massage the feet, shoulders, or hands, depend on the woman's performance. Any woman with allergy to any of the oil was massaged with grape oil only. Quality of studies and the outcome of can used during pregnancy-led birth. In recent years, the body of research investigated the outcomes of can used during pregnancy, labor, and birth has continued to grow. The majority of can have been critically reviewed in the last 3 to 4 years. The current research evidence is the outcome of can used in pregnancy, labor, and birth also largely overlooks the birth outcome as distant from labor outcomes such as the experience of labor pain and the use of pharmacological intrapartum pain measurements of women until came during pregnancy. Despite the high level of use came by women during pregnancy and birth, the current evidence that evaluate the effectiveness and the safety of can treatments and therapy in the context of the important life stage, while emerging remains limited in many areas. The evidence related to the outcomes of can use during pregnancy differ across can therapy. High level of evidence support the use acupuncture, yoga, and the individual herbal medicine for defined condition. Large gaps in our knowledge still exist for some therapies, which are frequently used by pregnant women or recommended by maternity health professionals, including chiropractic, osteopathy, and aromatherapy. A better understanding of the pattern of can use, including the approach to care of pregnant women by can practitioner is needed. A broader knowledge of safety of can use in pregnancy is needed. A range of effectiveness studies for pregnancy-related health conditions are needed, which focus on can products, treatments, and practice. Study with approach design and high epidemiological standard, including multivariation analysis, are needed before and the final conclusion can be drawn on the effect of specific can on pregnancy and the birth. And thank you for your attention. Thank you.
Thank you so much. We just finished our presentation for this session. And for the audiences, if you have any questions, maybe you can ask us.
Right. Thank you very much for the wonderful presentation from Professor Wang. What an amazing presentation. Right. Well, ladies and gentlemen, now we will go directly to the discussion session. If you have any questions, you might write down your questions in our chat rooms. So please, if any questions, you might now write down your questions through our Zoom chat room. Is there any questions? All right, seems that we have one first question. Yes, I have. Ibu Diana Trilestari, raise hand. Is that possible to have a live questions, Professor? Is that possible to now we have
Is the
okay.
It's okay.
Yes, of course.
Yes, of course.
Right. So
if it's safe, we can use the alternative therapy applied for women at any age of the pregnancy. It's okay. For example, ginger is okay, ginger, and aromatherapy, but it's needed to choose the oil. Not any oil is okay.
Hello, you can hear the answer very clearly, right? Or maybe I would like to repeat the answer again.
okay, please, sir.
Okay, the professor told us that actually for the alternative therapy, it is very safe to be applied for the woman, for all the women, especially for the alternative therapy we can use for some herbs that we can to find it around us, such as like the ginger. And also, as we know that if we want to use the ginger, most of the people, they would like to use something like the ginger that will be made from the oil.
For people.
Okay, thank you very much for the answer and the explanation from Professor Wang. And hopefully, to those who ask, your question is answered soon. And then now we go to the second questions from Ibu Zazu. I want to ask to Professor Wang. The question is effective hypnotherapy given during the final phase of pregnancy with tiring conditions for mother? So this is the second question, Professor Wang. Now you may have your answer and clarification.
Yes, yes, we can use the hypertherapy, but it need the teacher to teach, and the use is safe.
Okay. Right, so that was the answer from Professor Wang. Hopefully, to Ibu, yeah, your answer is done.
Yeah. Need hypertherapy. Need the teacher to teach when the pregnancy, the final phase. Maybe use in the childbirth is very better. Is very good for the mother. When childbirth is very painful, and we can use the hypnotherapy to during the childbirth. But it need to learn a lot, when the mother pregnancy.
Right, thank you very much, Professor Wang. So hopefully it answered the question from Ibu Mundriasuti. Then now we have a next questions from Dela. So the question is, for people who in a medical field, what is our role to maximize spreading some of the therapies, because not all of the therapies are really heard? So Professor Wang, so you may have answered these questions.
Yes, maybe I think when the hospital can use some books for the mothers, how to use the cam in during the pregnancy and the childbirth. Maybe use some books for the mothers.
Okay, so that's the wonderful answer from Professor Wang. Hopefully to those who asked, it can be answered. And now, do we still have another questions? Officer, do we still have another questions?
Acupuncture. It's also in Taiwan. So the acupuncture need the doctor, Chinese doctor to use. Not everybody can use. So in Taiwan, very rarely to hear the acupuncture during childbirth. Very rare. Yeah. But it's safe for when the women use the acupuncture can give birth. Is not during the childbirth very painful. Use the acupuncture is good for the mother. But
Okay.
need the doctor to use. Yeah.
Okay, so that's the wonderful clarification and answer from Professor Wang. And hopefully to those who asked, your questions is answered. Then now we go to the next question from Ibu Tiara Novi. I want to ask to Professor Wang, Indonesians are mostly afraid of doing acupuncture while pregnancy because they had worried of a childbirth. Then when is the best acupuncture given for a pregnant mother? So that's the question, Professor.
Acupuncture give for pregnant women in Taiwan is very rare, but the Chinese doctor maybe use the acupuncture when the mother is not comfortable or when the mother is vomiting or the baby, the contraction, and the Chinese doctor can use the acupuncture for the mother is very safe in Taiwan. But most of the mother go to the hospital, not use the Chinese doctor, not use the clinical for the Chinese doctor.
Okay, so that's a wonderful answer from Professor Wang. And hopefully, to those who asked, your questions are done. Okay, next we still have one question. So the question is from Ibu Zaju. So yeah, we have more questions, Professor. And the question is the aromatherapy can apply to a woman with a high risk of pregnancy? So can the aromatherapy be applied to a woman with a high risk of pregnancy?
When the woman her risk is a high risk woman use the aromatherapy. In Taiwan, most of the women high risk go to the hospital, not use the aromatherapy. Because maybe it's dangerous for mother. But when the mother is give birth, it's okay. Give birth is okay.
Right. Yeah, okay, so that was the answer and explanation from Professor Wang. It's better for the high-risk pregnancy goes to hospital now using acupuncture, but it's okay. So it could be it's given just 1 or 2 times. And yeah, so do we still have another questions? Yeah, so this discussion is going to be more interesting. Do we have still another questions from our chat room? No?
Maybe use the herb therapy, herb service. For example, use the ginger is safe, and some aroma oil, aroma therapy is okay. And some people use the acupressure when during the childbirth. Use the acupressure is better for the mother give birth.
Okay, so that's the answer and clarification from Professor Wang. Is there another questions? Yeah, the next question's coming from Ibu Diana 3. So the question is, I would like to propose my questions for Professor Wang. From several types of complementary therapies, what types are the most effective used in Taiwan? So which one is the most effective therapy used in Taiwan, Professor?
Maybe the acupressure is the most people to use. For example, when the mother gives birth, we can use acupressure to release pain.
Yeah. Yeah, so Professor Wang suggests to use acupressure, so it's going to be effective in Taiwan. So to Ibu Diana Lestari, hopefully your answer is done. And do we still have another questions? So this discussion is really interesting. Okay, so I still open 1 or 2 more questions if you have. Yeah, we still have 1 or 2 more questions, if any. Do we still have a question? Yes? No? Okay, so we still have 1 more questions. The question's coming from Ibu Hatul. I want to ask, is alternative therapy treatment more effective than treatment to a doctor? So alternative therapy treatment is more effective than the treatment to a doctor? So that was the question, Professor Wang.
Yeah, maybe I think the doctor is very is the first to choose.
Of course.
We can use another can to the mother, but if the women is very dangerous, maybe need to go to hospital. The first choose.
Yeah, of course, the doctor is the first option before you go the herbal or alternative treatment. So to those who asked, hopefully your question is done. Next, we still have? All right, we still have one more questions from Pak TV Bowo. Is that okay, Professor? We have more questions for today's discussions. Is that okay?
Okay.
Okay, thank you very much. Now, the question is, I want to ask my questions to Professor Wang. How is the spiritual healing therapy applied in Taiwan? Spiritual healing therapy used in Taiwan.
When the mother is Buddha religious, and the mother maybe can pray to the Buddha for
Yes, I get it. Okay. Yeah. So of course, when we deal with the spiritual, maybe we can go back to the religions, of course. Yeah. And to those who asked, hopefully your question is done. Next. This is one last question. Do we still have? All right then. So it seems that really interesting for today's discussion from Professor Wang, and I think there is no more questions, Professor Wang. And yeah, exactly, we would like to get more and more information from Professor Wang, and really amazing presentations. But then I'm afraid that we must close these sessions because we still have another presentations. And before this session is done, I'd like to ask, please give a closing statement, Professor Wang.
Thank you. Thank you for your attention. Thank you everyone.
Okay, so once again, now please let's give a virtual applause to Professor Wang for the wonderful presentation today. And right, I'd like to say also thank you, Professor Wang, and see you for the next presentation, Professor Wang. Thank you. Good morning.
Thank you. See you.
See you, Professor. Right now, yeah, the first presentation will be interesting, and don't worry, we still have another presentations. But before we move on to the next presentations, so I'd like to invite you to see the nice video from TIHTC. So now,
hello.
Let's end. Yes.
Hello, good morning. I am Krista from Taiwan International Healthcare Training Center, TIHTC. TIHTC is co-hosting today's event, and we would like to take this opportunity to share our training programs with you. I have sent the information to the chat room, so please check those out. And the first program I would like to share with you is the 2022 Healthcare Management and National Health Insurance Online Project Training Program. This program will have lectures of hospital information system, hospital financial management, the human resource, and we will also talk about Taiwan's national health system. And we have the testimonials of the previous year's alumni, and it's on our Facebook, so you are invited to check those out. And the second program we have is the emergency care and burn injuries, and I will share a video with you. So let me share the video with you.
experience in Changchun Memorial Hospital for these 2 years for the pandemic COVID-19 experience.
It is my pleasure to have a discussion with you about the emergency medical service system and disaster response system in Taiwan.
So today, I'd like to share the experience of TYGH.
Today, I would like to talk about Taiwan's emergency and disaster medical response system.
Today, I'm going to talk about monitoring in the emergency department. How can early warning system be applied?
We will discuss trauma evaluation and resuscitation.
Today, I will talk about something about hospital mass casualty incidents.
I will share my experience of shock management in ER and the DACPR in the fire department.
The minor burns can also clog the overtaxed burn system.
And the topic we are going to talk about today is the electrical injury.
Today, my topic is about the assessment of burns.
Today, I'm talking about the burn shock and fluid resuscitation.
I will be discussing it with acute burn rehabilitation.
Today I want to talk about acute nursing of burns.
My presentation will cover metabolic response and nutrition applied for burn.
Hello and welcome to this lesson on pressure therapy for burn scars.
Hello and welcome to this lesson on the management of post-burn pain development.
It has improved my experience and my knowledge about the emergency care.
Your disaster management system is very helpful to our country.
This training was very helpful when it comes to Somaliland people.
I would like to sincerely thank the SITC and the lecturers because of sharing useful experience with us. I hope to participate in the other classes from the SITC this year. Thank you.
For me to improve my knowledge and learn new things I did in health before. Good luck, Taiwan International Healthcare Training Center. Thank you so much.
Want to join the ranks of top international healthcare professionals? Join TIHTC now. Applications are now open. Your healthcare training platform of choice in Asia Pacific. Scan the QR code to fill out your application form. See you in Taiwan.
Okay, so these two programs are open for applications until November 7th. We're looking forward to having you in our programs. Last but not least, TIHTC is honored to collaborate with University Muhammadiyah of Kudus and the Indonesian Nursing Association. Wish all of you a fruitful day. Thank you.
Thank you very much for the wonderful video from Taiwan International Healthcare Training Center. Right, now let's move on to the second presentation. The presentation from Dr. Nguyen Thi Hoa Huyen, Nursing Program of College of Health Science, Vin University, Vietnam. Hello, Dr. Nguyen. Doctor?
Hello, everyone.
Hello. Okay. So good morning, how are you today, Doctor?
I'm very good and I'm honored to attend the meeting with you today.
Okay, right, seems that Dr. Nguyen is already with us now. Today, she will talk about postpartum depression management, a supporting program for a Vietnamese woman. And then before she delivers the wonderful presentations, let me read her curriculum vitae for a while. Dr. Nguyen has more than 16 years of experience in nursing field. She has worked for several colleges and universities to provide teaching and mentoring support to nursing students studying in diploma, baccalaureate, and postgraduate level. Dr. Huyen Nguyen is also an experienced researcher in the area of women's health, chronic disease, cancer, and nursing education. She has been invited to be a scholar member of Global Health Center at the University of Pennsylvania and Global Associations of Nursing and Midwifery. Currently, Dr. Nguyen is an assistant professor of nursing program at Vin Uni, where she works as program manager to monitor the development of the nursing program curriculum development. So that's the wonderful curriculum vitae. And to save our time now, let's go directly for the presentations. Doctor, the stage is yours now.
Right. So thank you for your introductions. So today my topics will be more specifically on postpartum depression management, with some program we are right now doing to support Vietnamese women. We expect that the program can be applied in the other countries, as we are applying the Women Wellness program developed by Professor Deborah Anderson in Australia. And the Women's Wellness program right now is adopted in over more than 7 countries over the world. So just go through the information of today's topics, and feel free to ask me any questions if you like. Right. So why women after giving birth and postpartum depression? So as you might see that a woman after they giving birth, they face a number of common postpartum changes, such as postpartum breathing, vaginal C-section healing, mood swing, or night sweats, or milk production problems. So with that change in their body, sometimes women, they feel upset, they feel depressed, or even they feel nothing, that they don't want to care for their baby. Some women, they even move to the higher states of psychological disorder. With that, we aim to address postpartum depression for the women, which can help improve the quality of life for the women and also their baby. So what is the postpartum depression? So our definition, or like an overview, is that the postpartum depression is considered as either mood disorder or mental illness, which is characterized by restless, anxious, fatigue, worthless, feeling that you make nothing meaning to the others. Blue mood, that means you feeling that even outside, the sunny skies are there, but you feel like the cloudy day. Low energy, and even suicidal ideation. So when the postpartum depression can be happened, it can be happen at any stage after birth and can be remain up to 2 years after birth. However, the depression with its onset often happen at the weeks 4 to week 6, and that might last for more than 2 weeks or up to 1 year, though it can happen 2 years later. The baby blues, that means feeling of blue moods, can start within early weeks of postpartum period. That can be happen just only 2 days after birth. So what is the prevalence? So we just have a review prevalence in the Asian region, and we found that about 36 women after birth having postpartum depression in Pakistan, or about 30% in Taiwan, or approximately 20% in Thailand. So let's guess how is it. Let's say we have 10 women in the room, and then if the women who are giving birth, about 2 to 3 of them may get the risk of postpartum depression. So the complication of the postpartum depression can be widely ranged. It can cause impaired physical, mental development for the children, or lower the quality of life for the mothers, or suicidal or self-harming behavior of the mothers, or even they can harm the baby. So we get the question of what is the postpartum depression prevalence in Vietnam, and how did it how was it researched? So we did a literature review of postpartum in Vietnam, and this has been published in the Frontier of Psychology. Though our review showed that from 2010 to 2020, we just have about like 18 research looking at the postpartum depression in Vietnam, and no study was performed among Vietnamese participants in the early stage after birth, especially the days within for the first 2 weeks. So seeing that the first 2 weeks, the woman has not been attended by the others or even themselves for the depression that might happen. From the first month to the third month, research reveals a wide range for the rate of postpartum depression in Vietnam, ranging from 8% to 34%. And you can see in the table here, these research, they mainly focus from the 1 month to less than 1 year of the after giving birth. So what are the risk factors? So our literature review of postpartum depression in Vietnam, in the publication, we found that a number of factors influencing to postpartum in Vietnam, postpartum depression among the women in Vietnam, including the low level of education, poor knowledge, or unwell prepared psychology to be a mother. So sometimes they just get pregnant and did not prepare themselves for having the baby. Unsatisfaction about new life after birth, history of mental trauma. So the woman who have the past history of the mental trauma may develop postpartum depression more than the others. Especially, we found that the family factors, especially lack of family support during the periods of postpartum, and poor relationship with family member, or even a problem with the child's health. So this means the women who have the child with more medical illness are likely to have the postpartum depression. They suffer from intimate physical, emotional, sexual violence, or husband preference of some. So here in Vietnam culture, in somehow, they still expected to have son other than having girl. So with that can cause the depression to the mother if they have a baby girl. Some environmental factors we have found, including stressful life events or rural living area. So women living in the rural or mountainous area are more likely to develop postpartum depression compared to the others. Or lack of social support reaction. This is highly noticed through our research that the mental health is not noticed by our healthcare system, or even by the women or their family member. So they more attended to the physical change or physical illness rather than mental illness. Some other environmental factors, including confinement practice. Right. So with that literature review, we aim to look at the prevalence of postpartum depression in a mountainous area of Vietnam to see how women they face with the postpartum depression and how they cope with us. Because the regionals and the belief in that area is more likely not not being noticed by healthcare system. So we done we just complete a current study survey in a mountainous area of Vietnam, which is the Sơn La province in the northern areas of Vietnam, close to the China. And this is a cross-sectional study conducted on 194 women who gave birth in the last 4 months. And the results shows us the prevalence of postpartum depression amongst the participants was quite high, accounting for 33.5% of the study participants. And 23 women sometimes had suicidal thoughts when they have the interview with us. And we found living area, monthly household income, or frequency of periodic health examination or alcohol consumption, perceive of infant excessively crying, practice or perception were considered as a predictors contributing to the postpartum depression of the new mothers. For more detail, we did also have a qualitative research in Cao Bằng province, and this research has been published in the Midwifery Journal. So with this qualitative research, we conduct the interviews on 18 individuals, including the mothers, fathers, and pregnant women. We also conduct 6 semi-structured interviews and 3 groups discussion at different community health center in Cao Bằng province. This province is also in the north mountainous areas of Vietnam. And we found that the parental knowledge about the maternal case was just at basic level. So they did not have any ideas of knowledge about the complication of childbirth or the complication of the pregnancy. Some expected behaviors such as home birth or poor attendance at maternal care health visits were found. Meaning that we found a number of ethnic women giving birth at home, and they just use some traditional methods to giving birth, or even like to sterilize the instruments they use for birth support. So with this, it might harm the woman or even cause infection after giving birth. So with that, to research results, we hope to develop a program to support women to reduce their postpartum depression and improve their quality of life after giving birth. So the question here is that how can we help the woman after giving birth? So we think that the proper guidelines and supporting system for timing advice is needed. And the intervention on all the education should not only focus on the woman, but also the family members to support them, to support women after they having birth, the friends, house staff, and the community to provide the training and support for the woman during their pregnancy and after their birth. So what type of delivery methods? We did a literature review and also did a research to see whether video tapings works for women living in mountainous area. Because we found in the previous study that the training session, face-to-face training session provided by village health workers in mountainous area is somehow facing some barriers due to the transportation and the difficulty of traveling in that area. So with this research, we examine the use of videos in delivering maternal education in mountainous area. And without this, we conduct a qualitative interview. The videos were confirmed to be an accessible and interactive and flexible tool supporting health education activities in this mountainous area. However, some health workers in the mountainous area struggled due to lack of technological skills and responsibility for their work. So that's why we are thinking of the program that can deliver online and with the consistent support of the health professional. Sorry, I need to move the slides. This doesn't work at this stage. All right. So we developed a program, a 12-week program package to support the women after giving birth. This package including the training sections about the pain management, about the physical trends, about the hygiene after giving birth, about how to feed the baby. We also provide more sections about the mental health problems that can happen after giving birth, including fatigue, sleeps, and how to get rest while they have the baby. We provide some training session about the emotional well-being through the physical activity or in exercise. And also the diet and nutrition for both mother and the baby, and how to return to the sexual life after giving birth, and about getting the social support from the family member or from the healthcare system. So here is the example of using the video to provide the training sections and the flyers and the podcasts about the training sessions we integrate into our program. So through this program, the women, they will be provided with the access to our website, and then they just like log in, and but in the daily basics, we provide the information, the education support, and also the video, the guidelines, the postcards, and the flyers for the women to learn themselves through that. So you can see here, the materials we included in our program, including video taping with health education content, and the postcards with key messages of caring for women and the newborn baby. The infographics, or we call it the flyers, the digital flyers as a reminder daily. And these all are integrated in the website for interactive activity. And we also provide the handbook for reference with full content in case that one day, if the women, they are unable to access to the internet, they still be able to go into the hard copy handbook and follow some instruction there. So with this women after giving birth program, we expected to promote mental and physical wellness of the woman, and women can be well performed of the self-care and caring for the newborn, and they reduce the risk of postpartum depression. So here's an example of our webpage. For example, when the women, they complete about like 4 weeks of the 12 weeks program, the loading will indicate that they complete about 20% of the program. Our expected outcome include to promote mental and physical wellness and empower women to well perform self-care and care for the baby and prevent women from the risk of postpartum depression. So what is the milestone screening to see whether any improvement in the outcome? We have the milestone screening as the baseline, week 0, week 6, and week 12 of the program. Along with us, we get the feedback of the mother about the program and whether they struggling with any supporting or symptom or just supporting or using the program. They want to ask any question. They provide us with the community chat box and even with the initiate chat box with the nurse who deliver the program. These 3 weeks, 3 time points assessment, we also assess the quality of life and record developing postpartum depression of the mother. So these early detections can help us to determine whether the mothers having the risk of depression, and with that, with the scale or the level of depression, we can provide a recommendation or intervention properly. So you might have the question, what are the ideas of the program? So our program is based on the ideas of the Women Wellness Research Collaborative, developed by Professor Anderson, at the Faculty of Health, University of Technology, Sydney. So her program was firstly developed to support the women wellness, the women in Australia, and then to support women with the chronic disease, cancer, or the women after they after having menopausal problem. Her program to translate objectives are to translate the new knowledge about the chronic disease risk factor in women into the cost effectiveness of health promotion activity to support women, health professionals, and policy makers to make informed decisions about the effectiveness evidence-based service provision. And the program applies the health promotion principles to cultural adaptations of the women's wellness program for women from culturally and linguistically diverse. So here is the core of the program, Women's Wellness Research Program. In this research program, Professor Anderson and her team developed different components to apply, including the health behaviors such as exercise, cognition, sleep, alcohol consumptions, diet, stress, or symptom management, or relationship and intimacy. And now the program is more to personalize the woman wellness. That means it can be driven to meet the needs of each woman individually. With that, the current projects, we collaborate with the Women's Wellness Program. We aim to develop the effectiveness and efficient empirical-based intervention target to reducing tobacco smoking, hazardous alcohol use. Why we say hazardous alcohol use? Because with the suitable alcohol consumptions that can help to improve the social activity and mental health for the woman. Yes, of course, it should not be applied for the woman with the pregnant women. Increase water intakes So why increase water intakes? The thing is that when we feel so much the mechanism, so in that way we feel so much like hungry, we eat more. But actually, that might be because of you feel so thirsty, and without having enough water intakes can increase more food consumption and increase the risk of developing obesity. We aim to improve diets and increase physical activity for participants. So the framework of these programs is underpinned by the development of lifestyle interventions, with improving the self-efficacy and providing women with a practice goal strategy for embedding wellness activity into their lives. So when we consider to personalize the program for the woman, we integrate the predictive, preventive, personalized, and participatory research among the women to design the program suitably. And now, with the development of the e-health or AI, the booming of using AI in a healthcare system, we aiming at developing the e-health or IT solution to deliver the program. So that's why in the women's wellness after giving birth in Vietnam, we integrated with the online, the web-based program to support the women more often, and they maybe feel more feasible to access the program. So here is some textbooks of the Women's Wellness Program developed by Professor Anderson and her team. And it all can be the hard copy or interactive iBooks through the website. And our Women's Wellness Research Collaborative is the evidence-based wellness research. And we are now expanding the program through over 7 countries over the world. So thank you for listening. And if you have questions, feel free to ask me.
Right. Thank you for the wonderful presentation from Dr. Nguyen. So, yeah, I know that every single postpartum mother will get really depressions, yeah, based on the research done by Dr. Nguyen. And now, to dig more information from Dr. Nguyen, now let's go directly to the discussion session. So if you have any questions, you may write down your questions through our Zoom chat room. Right, so the first questions coming from Andriana. Introduce my name, Andriana from University of Muhammadiyah Kudus. Permission to ask, what to do if the nurse accidentally neglect the action, while what is being faced is the patient's who is a critical conditions. Thanks. So first questions coming from Adriana, doctor. So the question is, what to do if the nurse accidentally neglect the action, and while what is being faced is a patient who is in critical condition. So what should we do if the patient will be in a critical condition? Thanks.
Right. So thank you. Very interesting questions. I think our program is a community-based program. That means we aim to support the women living in community living healthily in the community, including the woman after giving birth. So From the nursing community nursing perspective, we do not provide the treatment, the critical or the treatment for the critical illness, right? So we, as I have been shared with you about our assessment as a every time course of the program, we use the questionnaire to detect whether the woman's the high risk of postpartum depression, or if they report any critical illness. In that case, we might refer women to the health station or health centers. Though just we noticed that the program is an online program, so they just meet the nurse online, not in person. All right. So we also have the contacts with the health station and provide the list of the health station or hospital close to the community, so they can contact the hospital, or even we can support them to contact the hospital for the support if they are falling in the critical illness.
Right, thank you for the wonderful answer and explanation from Doctor. And hopefully to those who ask, so your questions is done. Now we go to the next questions. Question from Salsabila. I'd like to ask, when is the right time to start taking action to prevent postpartum depression? So that's the question, Doctor.
Yes, so the early training sections, the better preparation for the women after giving birth, and that means can prevent the postpartum depression for them. So our program is for the women at the weeks, can apply for the women from the week 0 of the program after they're giving birth to the week 12 of the program. However, we also provide some initial training for them and their family before they giving birth. So both the woman and their family member can be prepared before the woman's birth and prepared to support the woman after they giving birth.
Right, so that's the answer and explanation from Doctor. Of course, sooner better. So, yeah, when we can give sooner preventions, it could be better. And next questions coming from Eva Talia Nabila. Permission to ask, Professor Nguyen stated earlier that the role of the family is important to prevent postpartum depressions. How do we as a nurse communicate with the patient's family to prevent this? So how can we communicate to the family, Doctor, so to prevent the depressions to a postpartum?
Yes.
That's the question.
I think that's interesting and hardly to answer questions. Still the things we are considering right now for our program. As I shared in our presentation, we have the videos and also the flyers, the digital flyers for both women and their family member to learn and to read while they participate into the program. So when we recruit the participants or when women register for our program, we encourage them to invite their family members to join the program with us. So with the training sessions, not only the woman but family member can understand what the postpartum depression is and what are the changes of the woman after their giving birth.
Right, so that's the answer and explanations. So there is some training to not only a mother, postpartum mother, but also the training is given to a family. So to know what is the depressions. Next, that's a wonderful questions. Do we have still another questions? Right, the next question is coming from Mitra Sari. The psychological conditions of the mother during pregnancy is certainly influenced by the chance that occur on each 3 months pregnancy. Will the interventions be the same as in every 3 months to prevent postpartum depressions? So that's the questions, Doctor.
May I please make a clearer questions? Do you mean that the first 3 months after birth is more critical?
So maybe the question, show the questions one more, please. Officer. So the questions. So she may ask about the intervention will be the same in every 3 months. So the interventions of preventing postpartum depression will be the same or should be different? So,
right. So very interesting. Our program is 12 weeks program. So when the women they finish their 12 weeks program, they are free with the training. So meaning that we provide enough information for them to understand about their physical change and their emotional change after giving birth. As you may see, that's giving birth with a little baby who has not been with you before, but now she or he happening in your life. You have to spend your time for her, for him. And if the training is too long and too much, that may cause another stressful events to the woman. So we provide the program just on first 12 weeks, and then the account and the accessible to the program, the accessibility to the program still available for the woman in case that they want to review the flyers, the videos, the section program. They are completely be able to do so.
That's very fantastic answer. So to those who asked, hopefully your answer is done. Right, we move to the next questions, please. Coming from Ediwibo, I want to ask my questions to Professor Huyen. What is the instrument used to assess the quality of life and risk of the developing postpartum depressions of mother? So what is the instrument usually used? That's the questions, Doctor.
Yes, so as a researcher, you always think about the measurement scale, right? So here for our programs, we adapt the Women's Wellness Program developed by Professor Anderson in Australia. And as I shared with you before, her program is now adopted all over 7 countries. In our program in 7 countries, we use the same measurement of quality of life and some scale. We say the same with the aim to make a cross-cultural comparisons of the quality of life and also cross different disease or health stage, the health stage of the woman's life. So in our program, we use SF36 or SF12. Right now we use SF12 to reduce the number of patients. And with the postpartum depression, we use the Readiness scale. Thank you.
Right. Okay. So right, that's the explanation from Doctor. And do we still have another questions? Yeah. Seems like the second session is really, really interesting. All right then, so okay, so this is the previous questions. So we go next. Right, so questions from the YouTube from Siana Chikir. In some cases, it occurred that even the mother who had given birth to her child after many years passed, but she is still having a baby blues syndrome. Why does that happen? And does it happen on mom that? Does it happen on mom that? Okay, so why baby blues can always happen after the mother giving birth for many years? So that's the question, Doctor.
Yes, very interesting. Yes, of course, with our current busy life and a lot of responsibility are placed on the women. Depression, stress can happen at any stage of our lives, right? However, for postpartum depression, the definition right now who place that the depression happened during the first 2 years after birth. So if that happened later, after 2 years, we are not considered as the postpartum depression, but women, they face a mental health problem, which requires the caring and treatment for the mental health rather than like for a woman after birth. So yes, that's still the thing we have to consider. You may see that some women who experience postpartum depression and then it happen as the chronic condition if that not treated. If that condition is diagnosed or found just 2 years after, the minutes to get the help from psychologists or psychiatrists.
Okay, so that is the explanation from Dr. Nguyen. Then now, do we still have another questions? No? Okay. Seems that we do not have more questions, Doctor. So this discussion is really interesting. Right then, so if we don't have any more questions, now, once again, we would like to say thank you to Dr. Nguyen for the nice presentations. So she today talks about postpartum depression management. So now let's give a virtual applause to Dr. Nguyen Thi Hoa Huyen for the wonderful presentation. And before this session is closed, I need please give a closing statement, Doctor.
Right. So this is my pleasure to be here with you today, discuss more about our research projects, topics on the women's health topics. My very honor to share our perspective with you and hope that we can have more collaboration in research and teaching in the future.
Thank you very much, Doctor, once again. So have a nice day and see you to the next presentation, Doctor. Good morning and goodbye.
Yes, thank you so much and hope to see you.
Right. Okay, now, so we still have another session. Now let's move on to the third session, a presentation from Dr. Regie Bautista, System Pulse College Foundation in Philippines. So let me keep in touch with the Dr. Regie Bautista. Hello, Doctor. Have you been connected with us? Dr. Regie Bautista. Dr. Regie? Right, we are still waiting for Dr. Regie Bautista. And I'd like to say thank you to the dear participant who always joining this international webinar. Now we have about 270 participants joining in this webinar. Right, we are still waiting for the connections from Dr. Regie Bautista.
Iya, Ma. Sudah dapat kampusnya? Belum, Ma. Cari kampus itu harus yang benar. Yang sekiranya lulus nanti bisa langsung kerja. Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya mah, sudah dapat kampusnya? Belum mah.
Cari kampus itu harus yang benar, yang sekiranya lulus nanti bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya mah, sudah dapat kampusnya? Belum mah.
Cari kampus itu harus yang benar, yang sekiranya lulus nanti bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya mah, sudah dapat kampusnya? Belum mah.
Cari kampus itu harus yang benar, yang sekiranya lulus nanti bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya mah, sudah dapat kampusnya? Belum mah.
Cari kampus itu harus yang benar, yang sekiranya lulus nanti bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya mah, sudah dapat kampusnya? Belum mah.
Cari kampus itu harus yang benar, yang sekiranya lulus nanti bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya, Ma. Sudah dapat kampusnya?
Belum, Ma.
Cari kampus itu harus yang benar. Yang sekiranya lulus nanti, bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal yang aku senangi. Di sini tempat kita ngobrol dan diskusi. Inilah kampus.
Tahu kan gimana rasanya setelah lulus SMA? Pasti mikirin kuliah.
Iya, Ma. Sudah dapat kampusnya?
Belum, Ma.
Cari kampus itu harus yang benar. Yang sekiranya lulus nanti, bisa langsung kerja.
Kalian pernah kan ngerasain kayak gini?
Lakukan riset dan tentukan.
Aha,
Kuputuskan di kota inilah aku kuliah.
kuliah S1 Farmasi.
UMKU memiliki 3 fakultas dengan 20 program studi. Fakultas Ilmu Kesehatan, Fakultas Sains dan Teknologi, Fakultas Ekonomi, Pendidikan, dan Hukum. Tanpa keyakinan, tak ada yang mungkin. Namun, dengan keyakinan, tak ada yang tak mungkin.
Kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus. Hai guys, aku di sini melakukan banyak hal.
Universitas Muhammadiyah Kudus berada di kota Kudus, Jawa Tengah. Bermula dari penyelenggaraan SPK, Sekolah Perawat Kesehatan tahun 1984. Kemudian di tahun 1998, SPK konversi menjadi Akademi Keperawatan Akper. Di tahun 2004, berubah bentuk menjadi Akademi Kesehatan (Akes) dengan penambahan Akademi Kebidanan. Lalu menjadi Sekolah Tinggi Ilmu Kesehatan Muhammadiyah Kudus (STIKES) di tahun 2009. Dan pada tahun 2018 akhirnya berubah bentuk menjadi Universitas Muhammadiyah Kudus. Sebuah perjalanan panjang untuk mewujudkan universitas yang unggul, islami, berwawasan global, dan berjiwa entrepreneur.
Assalamualaikum.
Waalaikumsalam.
Selamat datang di kampus Universitas Muhammadiyah Kudus. Perkenalkan, namaku Rizky dari S1 Hukum.
Aku Andin dari S1 Farmasi.
Well, ladies and gentlemen, it seems that Dr. Regie has connected with us. Hello, Dr. Regie.
Hello, everyone. Good afternoon in the Philippines.
Fine. Yeah, we catch your voice. Okay. Right, so next presentations will be from Dr. Regie Bautista. Today, he will talk about reproductive health, pregnancy problem, and readiness. Before Dr. Regie deliver the wonderful presentations, so let me read a while his curriculum vitae. Dr. Regie Bautista is an academic reviewer nursing licensure examinations in the field of maternal and childhood nursing. Dr. Bautista used different approaches in knowledge transfer to his students that gained him the name as one of the most loved reviewer in the field. Again, Dr. Bautista earned his Bachelor of Science in Nursing cum laude and Master in Nursing from Angeles University Foundation. He earned his Doctor of Education in Philippine Christian University. He was also the recipient of Mayor Carmelo Lazatin Medal of Excellence in 2005. One of the 10 outstanding students of Angeles University Foundation in the community service category. Oh, that's great. Dr. Bautista was also nominated as one of the top outstanding students in the Region 3. That's a wonderful curriculum. Right, to save our time now, let's go directly to the Dr. Bautista. The stage is yours now, Doctor.
Okay, thank you very much for a wonderful introduction of my biography, and welcome to this webinar, and to all the participants there. Magandang hapon sa inyo lahat in the Philippines. So we are now using webinar, right? Zoom. Yeah, okay. So am I loud and clear?
Yes, okay.
Okay,
yes,
thank you very much. So my topic today is about the reproductive health, the pregnancy, the problems, the complications, and the readiness of this. So actually, the Filipino women's lives are changing rapidly as a result of improvements in education, the spread of the mass media, increases of proportions of women working, and growing acceptance of a larger role for women in society. While women continue to value their roles as wives and mothers, these developments have helped to redefine their childbearing goals. And the purpose of this webinar is to increase the awareness of these participants, what is in the RH law in the Philippines, and what is the what are the highlighting key changes in the reproductive health and the factors that influence it. The socioeconomic context in which they live, their success in planning the births and achieving their family size goals, and the extent of their use of contraception and abortion. I'll be discussing to you here, the Republic Act number 10354 on the Responsible Parenthood and Reproductive Health law in the Philippines. And this law, it is a Philippine law that provided universal access to methods of contraception, the fertility control, the sexual education, and maternal care in the Philippines. While there is a general agreement about its provisions on maternal and child health, there is a great debate on its mandate that the Philippine government and the private sector will fund and undertake widespread distribution of family planning devices, such as birth control pills, IUDs, and condoms, and as the government continues to disseminate information on their use through all healthcare centers. Passage of this legislation was controversial and highly divisive with academics. So religious institutions and major political figures in the legislature, heated debates and rallies, both supporting and opposing the RH bill, took place nationwide. And the Supreme Court of the Philippines, the highest court in our country, delayed the implementation of the law in March 2013 in response to challenges. And on April 13, 2014, the court ruled that the law was not unconstitutional, but struck down 8 provisions partially or in full. The history of reproductive health in the Philippines dates back to 1967, when Philippine President Ferdinand Marcos Sr. was among the heads of state who signed the Declaration on Population. The 30 overall countries who participated in the signing of the declaration was acknowledged by UN, by United Nations Secretary General U Tant, during a United Nations ceremony on December 11, 1967, a day after Human Rights Day. The Philippines agreed that the population problem should be considered as the principal element for a long-term economic development. Thus, the Population Commission was created to push for a lower family size norm and provide information and services to lower fertility rates. And now, okay, I'll be discussing to you, okay, this law wherein the Philippines has recently passed this as a responsible parenthood and reproductive health after several decades of controversy and public debate. And this law summarizes the elements, okay, of this reproductive health law, as well as the arguments and against its enactment. And actually, the Philippines Congress enacted this RA, or the Republic Act number 10354, on responsible parenthood and reproductive health on December 18 in 2012. And this is very important, okay, nowadays. It's very essential in the Philippines, wherein actually this law is quite a bit public controversy and political wrangling. And 3 days later, it was signed into law by the President of the Philippines, and commonly known as the RH law. And its implementing rules and regulations were due to come into effect last March 31, 2013. However, just 10 days before that, the Supreme Court of the Philippines issued a status quo or restraining order against this RH law for 120 days, and during which period it will review the petitions challenging the new law itself. So there are oral arguments before the Supreme Court had been set to begin on June 18, 2013, or 6 months since the enactment by Congress. And this webinar gives an outline of the elements of the new RH law and closes with a revisit of the many arguments and counter-arguments made for and against the bill then and the law now. So the question here is, what is reproductive health and their basic rights? As per the WHO, the World Health Organization, the RH, or the reproductive health, can be defined as the total well-being and proper functioning of reproductive organs in all phases of reproduction, and thus includes a complete state of mental, physical, and social well-being. There are numbers of programs which are directed toward maintaining reproductive health, and these programs include small ads and a few entertainment shows telecasted on the television for promoting safe sexual habits and awareness about various STDs or STIs, or the sexually transmitted infections. And all these efforts by the government and the non-governmental organizations, or our NGOs, aim at achieving a reproductively healthy society. Let us now understand more in detail about the reproductive health, followed by its problems and its strategies. So these now are the basic RH rights, wherein a person or an individual has the right to an information about the RH and the healthcare services for the safe pregnancy and childbirth. The person also in the Philippines has the right to know different means of regulating fertility to preserve health and where to obtain them, and where is the accessibility of these methods and of these materials, okay, as a part of the family planning methods. And this freedom to decide the number and timing of birth of children, and the right to exercise satisfying sex life. And actually, one of the selected concepts, okay, of this RH is to exercise the reproductive right with responsibility. And it means a safe pregnancy and delivery, the right of access to appropriate health information and services. That also includes protection from unwanted pregnancy by having an access to safe and acceptable methods of family planning of their choice. And also, in addition of this, is it also includes the protection from certain harmful reproductive practices and violence. So as a part of this, okay, in this area of the RH, it ensures also the sexual health for the purpose of the enhancement of life and personal relations, and assures the access to information on sexuality to achieve sexual enjoyment. Actually, in this RH, there are factors or determinants of the RH. This could be the socioeconomic conditions, the status of the women, the social and the gender issues, the biological, cultural, and psychosocial factors. So as we go along to my slides, I will discuss to you what is now happening, okay, in the RH, okay, in the Philippines, okay, according to the survey. And these are now the elements, okay, of these RH. This is your maternal and child health nutrition, the family planning, prevention and management of abortion complications, preventions and treatment of RTI, or including the STDs, HIV, and AIDS. As we all know, we are now in the MDG, Millennium Development Goal. In order to combat this, we have to attain the MDG number 6. So in this area also, we have to educate and counsel, okay, these individuals, okay, in terms of their sexuality and sexual health, to also to decrease and to prevent the possibility to have an STIs or these sexually transmitted diseases. These also give also an addition of an elements to the breast and reproductive tract cancers and other gynecological conditions, because one of the major leading causes of death and even also cancers in the females is breast cancer. And for also for the men's reproductive health is for about the testicular and the prostate area to determine here their health status. Adolescent reproductive health, violence against women, and the prevention and treatment of infertility and sexual disorders. The RH, it has the area of the goals and strategies, and these goals is very important in order to achieve a healthy sexual health and a sexual development and maturation. This also give emphasis, okay, to improve the use of the contraceptive methods of Filipinos, in order also for them to increase RH care, okay, that will also give them that also give them the outreach activities and referral system and prevention of RH problems, okay, specifically STIs, HIV, and AIDS. And this is very important by means of information and dissemination and counseling of these clients. And this RH law provides of the following, among other things. Number one of this is the midwives for skilled birth attendants. And the law here mandates that every city and municipality in the Philippines to employ an adequate number of midwives, okay, and other skilled attendants. Currently, only 57% of Filipino women give birth with the assistance of a trained medical professional. Okay, so we are lacking now of manpower. We are lacking now of resources, okay, in the Philippines in terms of this allied health. Okay. Number two of this is emergency obstetric care, that each province in the Philippines and in the city should ensure the establishment and operation of hospitals with adequate facilities and qualified personnel that provides emergency obstetric care. Number three is hospital-based family planning. Wherein here the law requires family planning services like ligation, vasectomy, intrauterine device implant or placement to be available, okay, in all government hospitals and even also rural health units. Contraceptive as essential medicines. As a part of this, reproductive health products should be considered essential medicines and supply, and should be considered essential medicines and supplies and should form part of the national drug formulary. So their inclusion in the national drug formulary will enable the government now to purchase contraceptives and not merely relying on the unpredictable donations. So in this also, okay, law, it provides also the reproductive health education, wherein here the RH education shall be taught by adequately trained teachers in an age-appropriate manner. Okay, he'll be in a high school, okay, into college, okay, to increase the awareness about the sexuality, okay, and the gender awareness. And even also the employer's responsibilities, that the employers shall respect the reproductive health rights of all their workers, that the women shall not be discriminated, okay, against in the matter of hiring, in the matter of regularization of employment status, or selection for retrenchment. Employment or employers here should provide free reproductive health services, okay, and education to workers. Okay, so this is now very important, okay, to a certain businesses, okay, a certain companies, that their employees must have these trainings and they have this education, okay, to this sexual reproductive health. And the capacity building, okay, for community-based volunteer workers, that these community-based workers shall undergo additional and updated training on the delivery of reproductive health care services, and shall receive not less than 10% increase in honoraria upon successful completion of training. Okay. However, okay, the law also provides for penalties for persons who perform certain prohibited acts. And these are the following, okay? So number one of these is knowingly, with malicious intent, withholding or impeding the dissemination of information about the programs and services provided for in this act, or intentionally giving out incorrect information. So it is punishable by law, okay? So these also law provides that refusing to perform voluntary ligation and vasectomy and other legal and medically safe reproductive health care services on any person of legal age on the ground of lack of spousal consent or authorization. Okay. Next, refusing to provide reproductive health care services to an abused minor or an abused pregnant minor whose condition is certified by an authorized DSWD or the social work official or personnel, even without parental consent, particularly when the parent concerned is the perpetrator. And lastly here, okay, the refusing to extend reproductive health care services and information account on the patient's civil status, gender of sexual orientation, age, religion, personal circumstances, and nature of work. Okay, actually here, okay, in this area of your our age, they also reiterated here that the large family size was closely associated with the poverty incidence. So example, if the family has children of 10, okay, or 15, okay, there will be an increase of the poverty, okay, or they are now in the below of the poverty line that is consistently borne out by household survey data over time. And now in the Philippines now, okay, they are now using now short or a small family size, okay, in order, okay, to increase, okay, the sexual health, okay, and the RH, the reproductive health, okay, in the family. According also here, okay, in the Family Income and Expenditure Service 5, okay, had unambiguously shown that poverty incidence was lower for families with fewer children, but rose consistently with the number of children. That the poor, that they preferred smaller families, except that they were unable to achieve their preference. Contraceptive use remained disturbingly low among poor couples because they lack information and access, and the lack of access of contraceptions had important health implications of this, and the risk of illnesses and premature deaths, okay, for mother and child, that alike were known to be increased when mothers, especially young mothers, had too many children that were spaced too closely. And multiparity, it also increases here the incidence, okay, of complications to the mother, okay, specifically the uterus, okay, and even also the fallopian tube. Almost 25% of less educated teenagers, okay, according to survey that they compared here, almost 25% of less educated teenagers began childbearing, compared with only 3% of those who had attended college or higher. So there is this 25% is very large amount, okay, in terms of a pie that indicates that there is an increase of teenage pregnancy in the country. And parents who were able to space their children, 78% of this, that the parents who were able to space their children and achieve their desired number were also more likely to bear the full cost of raising, educating, and keeping them healthy. And 100% these programs would lift the well-being of individual women and children and benefit the economy and the environment as well. So the Filipino here, okay, in the survey, that they favor an RH law while the Roman Catholic Church, okay, opposes. Okay, so by 2011, okay, surveys showed that nearly 8 out of 10 adult Filipinos, okay, favored a passage of the RH bill, okay, supported the provision of RH education to all and of free RH goods and services to the poor. So actually, it is a pity that the debate has been confined to a contraceptive because of the other elements of RH, which similarly protect and promote the right to health and reproductive self-determination and have been largely ignored. Actually, according to Dean Tony Lavina of the Ateneo School of Government, has this to say about the reproductive health law, that among others, it is clear that abortifacient methods are prohibited, freedom of conscience is respected, and there is neither a mandate to reduce our population nor a preference for smaller families. And in his views, the RH law's most important provision is the guarantee by the state to provide universal access to medically safe, non-abortifacient, effective, legal, affordable, and quality reproductive healthcare services, methods, devices, supplies, and materials which do not prevent the implantation of a fertilized ovum, and relevant information and education, and thereon according to the priority needs of women, children, and other underprivileged sectors. Helping women achieve their reproductive health and family size goal will require action of many fronts. So here, the circumstances in which a Filipino woman today becomes a wife, a mother, and a productive person in society are very different from those of the past. So though women's levels of education and participation in the country's development and have increased, there is also a large gap remain in their ability to achieve their reproductive goals. Actually here, as you can see, okay, in the area of your women's status, okay, the average woman in the Philippines, okay, today has 4 children. And whereas her counterpart 40 years ago had 7, 8, or 10. Modernization, the changing role of the women, severe poverty in some regions, the rise in the value of educating children, and an increased desire to improve the quality of life all have contributed to this reduction of fertility or a pregnancy. And here, over 80% of Filipinos identify themselves as Catholic because, as you all know, Philippines is a Catholic country, but their attitudes, as reflected in the survey and practices, indicate widespread rejection rather than the acceptance of Catholic teaching on contraception and sterilization. And it has been pointed out that 12, as a percentage of their total, more Catholics than non-Catholics supported the RH bill. And the debates were fiery and painful, but demonstrated that the only real objectors were the Catholic bishops and their staunch followers who insisted on their established position against modern family planning methods, specifically artificial contraceptives. Because Catholic Church wants to have natural family planning than the artificial. So apart from the Catholic Church, all other major religions in the Philippines supported the RH bill. Support also came from the Interfaith Partnership for the Promotion of Responsible Parenthood, the National Council of Churches in the Philippines, the Iglesia Ni Cristo, and the Philippine Council of Evangelical Churches. So as you look at here in the slide, these are now the main core, of the RH, that you have to assess. You have to look at the assessment in terms of the female and the male patient, the contraceptive methods, the HIV, the STIs, the fertility, the supporting the safe abortion care, okay, and information and counseling. And Filipino women, okay, want smaller families than they did before. Actually, there are certain journals or articles in the Philippines that induced abortion is one method that Filipino women use to meet their reproductive goals. Although abortion is illegal in the Philippines, okay, and despite the potential harmful consequences of an unsafe abortion for women's health and life, many women here resort to abortion to meet their family size goals or to space birth. So since the late 1970s, several studies have documented the occurrence of unsafe abortions and their negative impact on the women's health. So Filipino women abortion experiences cannot be isolated from their legal and sociocultural context. And the country's constitution defines abortion as a criminal act for which both the woman and undergoing the procedure and the provider who performs it may be prosecuted. So given these legal constraints and the positions taken by the Catholic Church that abortion is immoral and sinful, many women have little choice but to resort to an unsafe clandestine abortion when they are faced with an unwanted pregnancy. So in addition, the overall negative impact of this, or the climate of opinion of this on abortion, influences the attitude of healthcare providers, some of whom show overtly judgmental behavior toward women, and they treat for abortion complications. So about half of married women use contraceptives, and 4 in 10 users rely on traditional methods. Actually, in 2021, 48% of married women of reproductive age use a method of family planning, and about 60% of these users relied on the pill, relied on the modern method, okay, artificial methods, spermicides, injectables, okay, barrier methods, okay, or somehow male sterilization or vasectomy. However, 5 in 10 users depended on periodic abstinence, withdrawal, or other traditional methods which have a high failure rates compared to artificial. So women living in urban areas, okay, were more likely to practice contraception, and 70% of these than were rural residents, are 30%. So somehow there is a substantial proportions of women in both urban and rural areas that use traditional methods, and 21% and 19% respectively. So as you can see here, there are unintended births, okay, in the area of the provinces in the Philippines, and the high unintended births here is in the Eastern Visayas. Abortion, okay, is in the Metro Manila. Okay, there is also an increase of incidence of abortion, and actually abortion is illegal in the Philippines, but okay, there is a certain rule, okay, that if the patient, okay, is if the baby is very dangerous, okay, to the mother, okay, or the baby here has a problems or conditions and might lead to an a preterm delivery, okay, so abortion, it can be given, okay. However, okay, it must be practiced by a doctor, okay, practiced by a professional, okay, and also in a good or in a high environment of clinical setting. But in this area, okay, these are the unmet needs of the contraceptives. So as we all know, actually they are only balanced, but somehow there are women, they are not using of contraceptives because for them there are side effects, okay, because of them there are certain complications in their genital, so, and also it decreases the satisfaction, okay, during sexual activity. So here there is also a high proportion of Filipino women that need but are not using modern contraceptives. So in 2021, there are 50% of women did not want a child soon or did not want any more children, but they are not using a modern method. Okay, so here, actually, the proportion here is of currently married women with an unmet need of effective contraception is declined, okay, slightly during the 90s, okay, but still is very extreme, highly in 2015 that there is a 56% in the survey of women did not want a child soon or did not want any more children, but were not using a modern method. By comparison, there is a proportion of 58% in 2018, and the urban and rural women had similar levels of unmet need and similar patterns of change in unmet need in the 2015. So helping women here achieve their reproductive health and family size goals will require action on many fronts. Okay, so the circumstances here, okay, in which the Filipino women today becomes a wife, a mother, probably here, okay, the woman here is quietly busy, okay, in his career, that also decreases the possibility of to be fertile. So there are a lot of variations, okay, there are a lot of complications. That's why, okay, this RH law is a very controversial, okay, in the Philippines, okay, because the Catholic Church in the Philippines is also likely to have a strong influence in the provisions of this, okay, of contraceptive service. That given that it has been proactive in opposing modern methods. So the church here and other pro-life advocates support only one method of contraceptions, and that is natural family planning or the periodic abstinence. So according to the church, natural family planning also helps teach patients responsibility and self-control. So these statements ignore evidence that husbands' attitudes and behavior often prevent women from using contraceptive methods to achieve their reproductive goals. So furthermore, natural family planning methods typically they have a high failure rates. So in an analysis of this, okay, using information from 18 developing countries, including the Philippines, moreover, these rates were based only on contraceptive failures that resulted, okay, in live births because abortions were not measured. These rates underestimate method failure. So another important factor here that may have negatively influenced the provision of family planning services, okay, in the in 2000s, okay, there is a quite a devolution. Okay, so there is now an empowerment of these governmental agencies, the healthcare centers, okay, to increase the education in terms of sexuality and in terms of sexual health and reproductive health. And also, there are certain colleges of nursing that have these affiliations to the community to undergo certain mother class, okay, to teach these mothers, these families to prevent large size of families, okay, to use these methods, natural or artificial, okay, in order for them to have a birth spacing, okay, in their family. So actually, this is very important nowadays because the Philippines now, we have now a 110 million population. I don't know in Indonesia is how many are you in the whole country, but in the Philippines we are 110 million plus. So that indicates that there is now an increase of population, and as a part of this, the husbands or the partners may play an important role in influencing decisions about family size and contraception, and should therefore be included in the provision of family planning information and services. And women's ability to achieve their childbearing goals hardly improved during the 2000s, probably 2002, 2003, and there are many aspects of that, okay, that reverse occurred. So these circumstances strongly argue for increased attention by policymakers, service providers, okay, and advocates to identify and implement a mechanism for helping women to successfully plan their families, to reduce unintended childbearing, and thereby improving their reproductive health. Salamat. Terima kasih.
For the wonderful presentation from Dr. Regie Bautista.
And these are my references, okay,
Yes.
about the reproductive health, and also I want to also to express my references to this journal, okay, by Esperanza Cabral, that the former secretary of the Department of Health.
Okay, so now let's give a big applause to Dr. Regie Bautista for the wonderful presentation. Right? So I think we have really interested in the presentation, and now we go directly to the discussion session. So once again, if you have any questions, participants, so you may write down your questions through our Zoom chat room. Now, do we have the first questions? Right, the first question is coming from Salsabila. I'd like to ask, what programs are recommended to reach social economic for mother and children in Philippines? That's the questions, Doctor.
Thank you very much for the questions. So there are certain programs in the Philippines that giving by the government, okay, to these families, specifically by the Department of Health. It increases their education in terms of their sexuality, sexual health, reproductive health, and even also the use of these family planning methods. And there are certain programs by this agency, by the Department of Health, that to ensure, okay, the capacity of this family to raise children, to raise a child, okay, for their everyday life. Because as you all know, a large family size is very difficult because of the economic differences, because of the increasing of the prices of the goods and services in the Philippines. So I think this program is better. Actually, there are also programs in the health centers by means of program of Ligtas Tigdas, Buntis campaign. Okay, they have also this pregnancy mother classes, okay, to these communities to reach, okay, to those individuals are very poor, or these individuals are not educated, or they are not going to school, or these persons who are teenagers, okay, who are high risk to have pregnancy, okay, because of they don't know what is the meaning of the pregnancy, and what is now the purpose of that, okay, and they don't know the advantages and disadvantages of that.
Right, thank you for the wonderful answer and explanation from Dr. Regie. So hopefully those who asked your question is done. Right, so now next to the next questions. Right, the questions coming from Diana Tri. Thanks a lot for the best presentation. I'd like to ask to Dr. Regie, what are the regulations applied by the government in the Philippines related to the maternal health during pregnancy until the childbirth? So that's the questions, Doctor.
There are regulations applied here, okay, in the Philippines, okay, related to the MCN, or maternal child health nursing, during the pregnancy until childbirth. Actually, the Philippines has its program of the PhilHealth. It's a national insurance agency that if the mother, okay, will give birth to a certain public hospitals or a certain lying-in clinics, they are free from paying such hospital fees or hospital bills. Second is if the baby here, okay, delivered has no complications, and it will be given a vaccination. Vaccines are free, okay, in the health centers. Okay, there are also free checkups, free prenatal care, okay, to these healthcare services, specifically to these rural areas, because in the research there are a lot of women, okay, in the rural areas have certain complications because of the transportation, or the length of the traveling, okay, from the health center to a certain area of their living. So here, one of the major protocol and major regulations here is to give educations by these nurses or midwives, okay, in each provinces or in each cities, okay, in the country, okay, in order to educate these women or these families about maternal and child.
Right, so that's the explanation from Dr. Regie. Now next we go to the next questions from Mr. Anwari. Okay, show the questions please. So we still have more questions, Doctor. Seems that this is really wonderful presentations. Right.
I think the question of Mr. Anwari is what is the proper handling desirable pregnancy cases, especially in the Philippines?
Yes. Okay.
Yeah. Actually, okay, the proper handling of undesirable pregnancy cases, especially in the Philippines, the proper handling of undesirable pregnancy, these are the complications during pregnancy, right, Mr. Anwari?
Yeah. Okay. The proper handling of desirable pregnancy.
Yeah. So if ever there are complications, okay, of these pregnant mothers, okay, they will go to a certain hospitals, okay, for a certain checkups, or if the patient is bleeding, okay, there will be a certain checkups, okay, or prenatal care. There is also integrated management for pregnancy and childbearing. Okay, there is certain tool or a certain practice here, okay, in the Philippines, that number one, actually I think in the WHO and also the DOH agrees here that the mother now has the right to choose a position she wants as long as she is comfortable. In the delivery of the baby, okay, in the traditional way, the mother is in the lithotomy position. Okay, the mother is in supine lying. Okay, and the legs are lifted. Okay, however, okay, in the new trend, okay, in the new way of delivery, is the mother has the right to choose a position she wants as long as she is comfortable. That's why there is a bathtub delivery. There is also a sitting delivery, okay, in order to decrease the possibility of lacerations and complications during the delivery, or specifically the perineum. Number two is there is no shaving of the pubic hair, okay, because there is a research that says that a pubic hair, it increases the strength of the perineal area. It prevents also a certain infection, okay, because if the nurse, okay, has a certain blade, okay, or razor, okay, razor blades, okay, he will shave, okay, the perineal part, okay, of the mother, and there is a tendency of a wound or lacerations. There is now a chance of the portal of entry of the organism, okay, to have infection. Okay, so there are a lot of trends, there are a lot of ways, okay, now of practices of delivering of the baby. But if there is undesirable pregnancy, just like of rupture placenta, bleeding problem, placenta previa, okay, and even also ectopic pregnancy, there is an immediate, or there is referral, okay, to the hospital as soon as possible.
That's the explanations from Dr. Regie Bautista. So hopefully to those who asked, your answer is done. Right, so now we go to the next questions, if any. Right, no more questions? We still wait. If there is anyone to one or two questions, we still open a discussion.
I just want to also to add, if the mother has a normal delivery, okay, it's okay to deliver in the health center. However, if the patient mother has complications, she will refer to a district hospital or a certain private hospital.
Okay, seems we have one more questions. Show the question, please. The question from Akmal. The question is how to raise awareness about the importance of using contraceptions, because many people need it but choose to refuse. Okay, so how to raise the awareness of importance of using contraception? That's the question, Doctor.
Thank you very much, Mr. Muhammad, for the very good question. Yes, many of them, they are refusing to choose a contraception or contraceptive method. However, in order to increase the awareness of this is through proper education and proper dissemination. And it could be TV ads, it could be a mother's class, or a certain distribution of pamphlets or brochures that this is the advantage and disadvantage of this certain product or certain method, in order for them to be knowledgeable about that method. Because one of the major problem why RH or reproductive health law or these contraceptive methods are have a failure rates because of the education. They are not properly disseminated. They are not properly used in a proper way of that certain method. That's why there is a failure rate of this family planning.
Thank you. So that's the explanation from Dr. Regie. Hopefully, to those who ask, your answer is done. Okay, now do we still have another questions? No? Seems that we have no more questions, Doctor. And yeah, so before we close these sessions, I'd like to say thank you and please give a virtual applause to Dr. Regie Bautista for the wonderful presentation today. But before we close, I need to please give a closing statement for Dr. Regie Bautista to end this session.
Thank you very much. Actually, there is no perfect contraceptive methods as long the husband and the partner has a very good role in influencing the decision about their family size and the use of contraception. They have to have a very good family. They have a very standard family, and they will have a very good living in this era. Okay, however, here, women's they have the ability to achieve their childbearing goals. Here, I encourage everyone. I encourage the mothers to increase their awareness, their education about these contraceptive methods. They have to read certain books or certain YouTube videos about these contraceptive methods in order for them to be knowledgeable, and to determine the advantages and disadvantages of these products.
Thank you very much for a closing statement. And once again, let me say thank you very much for the wonderful presentation today. And Dr. Regie Bautista, have a nice day. Thank you very much. See you soon in the next presentation. And good afternoon, Doctor.
Thank you. Terima kasih.
Okay, sama-sama. Goodbye, Doctor. And right then, so in this morning and in this today's webinar, so the topic is really, really interesting. And we still have another presentations. Yeah, we still have two presentations from our university lecturer. So the fourth presentation will be from Ibu Noor Hidayah. So let me keep in touch with her before the presentation. Hello, Ibu Noor Hidayah. Have you been? Okay. So seems that Ibu Noor Hidayah had been connected with us. Today she will talk about pre-contraception care. Right, before she deliver the wonderful presentations, let me read her curriculum vitae verse. Her full name is Noor Hidayah, and then now she lives in Undaan Tengah, RT05 and R03, and then now she is a lecturer at Muhammadiyah University of Kudus. She is also a vice rector of Muhammadiyah University in Kudus. And about her educational background, so she completed the bachelor degree in Universitas Karyati, and then she goes for the master degree at University Diponegoro University. Right, to save our time, so now let's go directly to the presentation delivered by Ibu Noor Hidayah. The floor is yours now, Ibu Noor.
Okay. Oke. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, happy ladies and gentlemen. I will present my material today with title Preconception. With title Preconception Care to Prepare Ahead Pregnancy. Part the cycle of woman's life, preconception, conception, and pregnancy, which I will describe here on the aspect preconception. The definition of preconception: pre means before, and conception means meeting process of an ovum with a sperm. Preconception, it is also known as fertilization. What is preconception care? Preconception care is one of the efforts to prepare health behavior, physical and mental, to provide intervention to prospective parents. It is as an effort to prepare a health pregnancy. This slide, maternal health condition. In Southeast Asia and Indonesia, number 3 in maternal mortality. From Myanmar and Laos. Data from MDGs 2015 Indonesia is one of the countries that failed to reduce maternal mortality rate to 102 per 1,100 live births. Data RKPD Kudus Agency 2021, the pregnancy rate in Kudus is totally 7,973, in which 9,502 cases are mother with high-risk pregnancy and 121 cases with very high-risk pregnancy. High-risk pregnancy contributes to causes of maternal mortality in Indonesia. This slide, causes of maternal mortality in Indonesia. The Thales etc. And number 2, bleeding. Maternal mortality main causes: number 1 bleeding, number 2 hypertension, and number 3 anemia. Anemia is Hb less than 10 gram. Defining factor maternal mortality: pregnancy complication, labor complication, and maternal disease history. Nah, preconception care with physical check-up, nutrition of intervention, lifestyle improvement, intervention, infectious disease, immunization, and physiological service. To prepare conception, it is starting from adolescent with reproductive organ health, need a balanced nutrition and health lifestyle. 6 months before pregnancy. Number 1, don't eat foods that hasn't a variety of nutrient. Increase your intake of vegetable, set disease, and fruits. Pay attention amount of consumption, avoid overeating one particular type of food and drink. Reduce consumption of preserved processed food, consumption of food and drinking that contain antioxidant, and start drinking fluid acid. 6, planning a health balanced pregnancy. Enrich knowledge about pregnancy, birth, and care from various sources. Stop bad habits such as smoking, drinking alcohol, stress, etc. Keep to diet. Check up inner balance. Prepare yourself to change. Okay, thank you. I return to Mr. Safik. Assalamualaikum warahmatullahi wabarakatuh.
Thank you for amazing presentation from Ibu Noor Hidayah. Right, so to save our time and then to dig more information about the presentations from Ibu Noor Hidayah, now let's go directly to the discussion sessions. Again, I still open the questions. So if you have any questions, you may write down your questions through our Zoom chat room, or you may ask directly to the speaker, Ibu Noor Hidayah, for today's presentation. Any questions? Any questions, Ibu? Dear participant? Is there any questions? We still wait if we have any questions. Seems that we have the first semester. First questions. Okay, so the questions from Johar. An interesting presentation from Mrs. Noor. Why did Indonesia fail to achieve the target for reducing the MMR? We know that the budget allocated for maternal and childhood program is very large and is a priority program for the state. So that's the questions from Mr. Johar. Ibu Nur Hidayah, please give the answer. So, Ibu Nur Hidayah, you may speak in both bahasa Indonesia or English. So, you may answer and explain in bahasa Indonesia or in English.
Terima kasih Pak Safek.
Yes.
Mohon maaf, bahasa Indonesia saja bagaimana?
Okay. It will be okay, Bu Nur, so you may give a clarification or answer in bahasa Indonesia.
Saya tadi pertanyaannya apa tadi?
Right.
Pak?
Show the questions one more, please. The question. So the question from Pak Johar, if I translate it into bahasa, kenapa di Indonesia gagal menerapkan, achieve atau mencapai target untuk menurunkan MMR? Kita tahu bahwa alokasi budget untuk ibu hamil dan juga kesehatan anak, program kesehatan ibu dan anak itu sangat tinggi dan menjadi prioritas, program prioritas bagi negara. Tetapi kenapa program ini gagal gitu ya untuk menurunkan angka MMR? Terima kasih.
Terima kasih Pak Johar untuk pertanyaannya. Terima kasih Pak Safi. Terkait dengan kenapa sampai dengan saat ini Indonesia masih termasuk kategori negara yang gagal untuk menurunkan MMR, ini ternyata banyak faktor ya. Untuk tahun kemarin hasil data di RKPD tahun 2021 ini faktor kegagalannya diantaranya karena kasus COVID begitu ya. Kemudian untuk di pelaksanaan di lapangan ini sebetulnya pemerintah sudah memprogramkan banyak ya, mulai dari pentapisan awal untuk ibu hamilnya sebelum hamil dan ibu hamilnya itu sudah ada program untuk penata laksanaannya, tapi ternyata di lapangan itu contoh untuk yang prakonsepsi nih, Pak. Data di lapangan itu ibu hamil sebelum menikah itu kan harus dilakukan pasangan, bukan ibu hamil saja, dilakukan pemeriksaan awal di puskesmas. Ada 4 hal yang harus diperiksa itu. Ada pemeriksaan ini gizi ya, kemudian pemeriksaan penyakit menular ya, Ada 4, saya ini mohon maaf, saya agak lupa, tapi ada 4 hal yang diperiksa di puskesmas, baik kepada calon pengantin laki-laki dan calon pengantin perempuan. Tapi kenyataannya di lapangan itu tidak semuanya calon pengantin itu melakukan pemeriksaan, ya. Jadi contohnya yang tidak melakukan pemeriksaan adalah calon pengantin yang menikahnya itu usianya kurang dari 19 tahun. Begitu. Jadi dia harus melakukan memohon izin kepada Departemen Agama ke Depak itu untuk apa itu namanya ya, semacam ada nama tersendiri gitu, sehingga dia dengan mendapatkan surat dispensasi nikah itu, dia bisa sudah langsung melakukan pernikahan ya, tanpa melakukan pemeriksaan di puskesmas ya. Dengan kejadian itu mengakibatkan pentapisan awal itu tidak terjadi ya, atau gagal, sehingga istilahnya banyak ibu hamil yang terjadi kehamilan risiko tinggi dan menyebabkan kehamilan yang secara penelusuran awal itu susah ditelusur tadi karena datanya tidak ada. Itu salah satu contoh. Kemudian kalau untuk yang persalinan dan kehamilan sebetulnya banyak data, tapi untuk yang data awal saya itu yang saya lebih tahu itu untuk yang prakonsepsi ya, sebelum melakukan pernikahan. Mengatakan Pak Johari.
Right. So yeah, that's the explanation from Bu Noor Hidayah. Hopefully it can be understood by Pak Johar. Your question is done. Okay, we still have another questions. Do we still have another questions? No? We still wait one more questions, if any? No? No questions? Okay, seems that we don't have more questions, Bu Noor Hidayah. Sepertinya kita sudah tidak punya pertanyaan lagi. Right. So for the wonderful presentation, Bu Noor Hidayah. So before we end this session, so please give a closing statement, Bu Noor Hidayah. Kalimat penutup untuk presentasi.
Terima kasih Pak Safe. Jadi untuk menciptakan kehamilan sehat, ya ini tidak cukup dilakukan pada saat seorang wanita dinyatakan hamil, tapi dilakukan pada saat wanita itu belum merencanakan untuk hamil, pada saat masih usia remaja. Ya, jadi tadi dengan sudah disampaikan di awal tadi, menjaga makanan, kemudian persiapkan fisiknya supaya tidak stres ya, dan diantaranya ada minum asam folat sejak awal ya, untuk mencegah kehamilan yang tiba-tiba biasanya kan tidak direncanakan itu tiba-tiba hamil begitu kan wanita itu, supaya tidak terjadi masalah dalam kehamilannya. Prinsipnya untuk menciptakan kehamilan sehat adalah perlu dipersiapkan sejak awal, sejak wanita usia remaja, sejak sebelum merencanakan kehamilan. Mengatakan Pak Safi.
Baik, thank you very much for a nice closing statement. Intinya, jadi kehamilan itu perlu dipersiapkan. Nah, begitu nggih kurang lebihnya. Baik, thank you Bu Noor Hidayah for the wonderful presentation. I see you in the next presentation. Thank you Bu Noor. And now we go to the last presentation from Ibu Sri Karyati. So now let me keep in touch with Ibu Sri Karyati. Have you been connected with us, Ibu? Ibu Cici?
Thank you.
Okay, so seems that Ibu Cici had joined for today's webinar. Then today, Pujici will talk about a wonderful presentation. So before she delivers the wonderful presentation, so let me read her Kilgrim Vitaverse. Yeah, she today will talk about premarital screening, checkup, and counseling. Right. So her full name is Sri Karyati. She was born in Kudus, 2 of August 1974. Now she is a lecturer in Muhammadiyah University of Kudus. Her education, she is a specialist in maternity nursing. And the research has been done by Ibu Sri Karyati. There are so many. So, but she is famous with the research entitled Desain Penguatan Pelaksanaan Fungsi Legislasi Dewan Perwakilan Rakyat Republik Indonesia menuju Pembaruan Hukum Nasional Pelaksanaan Pendampingan Pembuatan Plegolik pada Ibu PKK sebagai upaya pencegahan penyakit hipertensi. Okay, to save all time, let's go directly to the presentation delivered by Ibu Sri Karyati. The stage is yours, Mom.
Okay, thank you, Mr. Shafiq. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon. How are you all? How are you, Mr. Shafiq and...
Okay.
Okay, everyone wants a lasting and happy marriage and has good offspring, but not all couples can get what they want. Some of them cannot get married happiness due to failure to understand each other or inharmonious communication or inability to solve problem in marriage. Sometimes their happy life has to be tested with the hot condition of themselves, their partner, or their offspring due to an unpredictable infection disease or hereditary disease. For this reason, it's necessary to anticipate and be prepared to overcome problems that may arise in marriage by the premarital screening, check-up, and counseling. Premarital screening check-up is a series of, I'm sorry. I'm sorry. Okay. Okay, premarital screening check-up was a series of tests that couple had to do before marriage. Premarital screening is highly recommended for couples who are about to get married because not everyone has a good medical history. Healthy-looking people can have disease-carrying properties. It must include genetic examination, infection disease, and infection through the blood. The examination aims to prevent the disease from decreasing in the offspring in the future, so that a healthy life with the family can be achieved. The purpose of premarital screening check-up is prevent the occurrence of health problem or disease transmission to oneself, spouse, or offspring in the future. If one partner has an infection disease, for example, HIV, then if this is knowing from the beginning, then both of them can anticipate transmission prevention and plan to have children safely. Second, to prevent various diseases in future babies, such as thalassemia, or diabetes, and other diseases. If from the beginning one of the partner or both have genetic carriers or of thalassemia, for example, Then they can discuss planning to have children or not, with all the consideration and consequences, so that if one day they have a problem, they are ready to face it. Premarital examination is carried out to get to know the medical history of oneself and one's partner, so that there is no regret in the future, especially for the resulting hereditary history. Make the bride and groom more steady, more open, and more confident in each other regarding the medical history of the birth. That is the premarital screening stats. Maybe okay. We often find around us couple who initially look happy suddenly experience domestic turmoil, even to the point of divorce. Why? Many causes. The most common cause is failure to unify the vision in the household. Why? Don't they love each other? Yes. At first, they love each other. You know, love is plain. When someone feeling in love, she or he will, we say, bucin, become budak cinta, you know. They only care about the present, don't care about what they will face in the future. So, because they do not have enough knowledge and understanding of many things that must be passed in a household, then even small problem can be the cause of rift in the household. Then this is the importance to premarital counseling. Premarital counseling is a helpful relationship process between counselor and client in terms of providing education and guidance on preparation marriage and how to build a household for the future good. Now, there are many premarital class programs. If you want one based on your religion, Islam, Christian, it's other, that there's two. The marital class is program designed to help and make it easier for prospective bride and grooms to gain knowledge about how to build a nice household according to guidelines, so that a happy family can be created. In class, we will get a lot of material, include knowledge about household management or marriage management. This material will be reviewed both in terms of religion, law, culture, and scientific, of course. We will also get household guidance, how we should behave to our partner, how to communicate, how to manage finance. One of the purpose of marriage is to have children. Of course, not just having children, but nice children who are smart and healthy, physical and mental healthy. This will be achieved only if parents who apply the right parent style. In class, couple will also get the material. Consulting service are also provided to unravel and help them resolve the problem that exists between them. As we know, no human being is the same, especially in their thought and feeling. Marriage is not to make them the same, but how the different can understand, respect, and complete each other. So, premarital counseling also provides an understanding of reproductive health and stunting preventions too. So far, many people do not understand the importance of condition before the concepts process or preconception. So that perspective, father and mother only concentrate on pregnancy and childbirth. A healthy pregnancy requires physical and mental preparation. We will plan pregnancy process will have a positive impact on the condition of the prospective mother and fetus. Counseling will increase the knowledge couple about premarital preparation and as an effort to prevent complication of pregnancy and childbirth, even during the postpartum period and after. Benefit of the premarital counseling, we have pursued in merit, have a goal of vision to be achieved in the household. We will more focus on achieving their goal. It is easier to unify the vision despite all the different nature between them. Help understand the couple family, because we do not only live with a partner but also a family around us. So improve communication skill. You know, the key of problem solving is in communication as well. There is no there is no merit, there is no vulnerable, but with preparation, problem and family are relatively more manageable than those without preparation. Class will motivate and strengthen marriage commitment and build an household, so that external temptation, such as we say pelakor, pebinor, can be more overcome. It's give an overview of problem in the household, conflict management in the household, and understanding domestic violence and prevention so that domestic violence does not happen. Okay, premarital screen check-up and counseling hinder or complication demerit, but to it's not to hinder or complicate the marriage, but to help the couple to be better prepared to face all the problems that may arise after the wedding. No one is perfect in the world, so don't force our partner to be someone perfect. Also, don't be discouraged if we're not perfect either. Married life will be happy and lasting if both partners can understand each other, respect, and feel each other shortcoming. Okay, thank you, Mr. Safik.
Presentation from Ibu Sri Karyati. What an amazing presentation. So if I can conclude the presentation is marital counseling is a must to a teenager. Yeah, because there are so many problems arising after the problem, so we can prevent, we can minimize the problem happened after the marriage, right? So now to dig great information about the presentations, now let's move on to the discussion session. I invite again the participant to join for the discussion session. If you have any questions, clarifications, or argument, so you may write down your questions in our Zoom chat room. Please, do we have a questions? Okay, so the first question from Diana Tri Lestari. The question is, what should be prepared when starting a pregnancy program? So that's the questions. Bu Sri Karyati, you may answer that.
Okay, thank you. A lot of prepare when starting in pregnancy program. Miss Noor Hidayati explain about that. In Indonesia, okay, Mr. Syafiq?
Okay, of course, you may answer that in both Bahasa Indonesia or in English. It's okay, we'll be okay.
Yeah. A lot of prepare when will be prepare when starting a pregnancy program. Bu Noor Hidayah tadi sudah menyampaikan about the preconception, about apa yang harus dilakukan, ya, nutrition, healthy. Tetapi menurut saya tidak cukup prekonsepsi, tetapi persiapan ini adalah sejak sebelum pernikahan. We know that problem of pregnancy is not a problem physical health only, but mental healthy too. So if the couple is unharmony, have a problem in household, itu akan mempengaruhi kehamilan. Oke? Jadi ketika dalam rumah tangga itu ada permasalahan yang tidak terpecahkan dan itu menjadi pemikiran, menjadi masalah psikologis bagi ibu, maka ketika ibu itu hamil itu juga akan mempengaruhi. Sehingga menurut saya persiapannya adalah jauh-jauh sebelum pernikahan. Jadi ketika sudah masuk ke pernikahan, secara fisik sudah benar-benar siap, secara mental juga benar-benar siap, dan yang terpenting secara kognitif pengetahuan mereka juga sudah siap. Jadi ketika kehamilan itu bukan hanya menghadapi kebahagiaan saja, tetapi juga ada krisis maturasi, ya. Ketika hamil juga ada kondisi krisis, itu akan menyebabkan perubahan secara psikologis. Ketika pasangan tidak siap, itu juga akan menjadi permasalahan. Salah satu yang bisa menjadi penyebab permasalahan tadi yang sudah disampaikan pembicara sebelumnya menjadi postpartum depresi. Jadi banyak sekali, ya. Jadi persiapan secara fisik, secara mental, pengetahuan, dan tentu saja secara finansial. Meskipun uang bukan segala-galanya, tetapi ketika terjadi kekurangan keuangan yang kacau, itu juga bisa menjadi salah satu faktor yang bisa mempengaruhi. Thank you, Mr. Syafiq.
Okay, so that's the wonderful explanation from speaker Ibu Sri Karyati. Hopefully, to those who ask the questions is overcome. Now we go to the next questions, if any. Show the question, please. Okay, the questions from Mr. Anwari. The question is, what are things should be avoided for pregnant mother? Should be avoided for pregnant mother. So what things should be avoided?
Oh, sorry. What?
What things should be avoided for a pregnant mother? If I can translate it into bahasa, hal apa saja yang harus dihindari Nah, bagi ibu hamil.
All of unhealthy. All of unhealthy. Kita hidup di Indonesia itu banyak ya yang mempengaruhi. Kesehatan itu kan banyak dipengaruhi oleh budaya, agama, ya. Banyak sekali yang mempengaruhi, juga ekonomi. Kalau kita bicara tentang apa yang harus dihindari, ya everything unhealthy. Okay, you know, example, alcohol, or drug, junk food. I think that is all harus dihindari. Banyak. Jadi ketika hamil, bahkan sebelum hamil, itu gaya hidup, pola hidup, lifestyle, itu harus dirubah menjadi healthy lifestyle. Healthy lifestyle. Activity, nutrition, rest, and stress management. Must doing. Ya, jadi banyak yang harus dilakukan, dan yang dihindari itu semua hal yang tidak sehat itu harus dihindari. Terkait dengan budaya, ketika ada budaya yang meskipun itu tidak terbukti, ketika budaya itu susah untuk dirubah. Mudahnya itu adalah dimodifikasi, bukan dirubah. Jadi ketika ada budaya yang mungkin tidak sesuai dengan kesehatan, kita mengatakan langsung cut, tidak boleh gitu ya. Itu biasanya secara kesehatan fisik tidak berpengaruh, tidak bermasalah. Tapi ingat bahwa ibu juga ada kesehatan mental yang harus diperhatikan. Jadi ketika budaya itu dipaksa untuk dirubah, padahal ibunya itu menjadi tidak yakin, itu akan menyebabkan permasalahan secara fisikal, ya, secara psikologis, secara emosional. Jadi ketika ada budaya, cultures yang tidak sesuai dengan kesehatan, maka langkah kita adalah modify, ya, memodifikasi budaya tersebut.
Okay, so right. Ibu Sri Karyati, masih ada penjelasan? Does it have more explanations?
No, thank you.
Someone? Okay, so that's the wonderful answer and explanations. Jadi kita harus melakukan budaya hidup sehat ya, live healthy. Nah, jadi kalau ingin yang harus dihindari oleh ibu hamil. Okay, so thank you. That's the explanations. Hopefully to those who ask, your question is done. Right, we go next to the next questions, if any. We still have one questions. Right, a great presentation from Mrs. Sri Karyati. We know that in Indonesia is a country with many health problems. So far, how has the success of this premarital assistance program implemented in Indonesia? What needs to be developed next so that it can reach all levels of society? So that's the questions from Mr. Muhammad Jauhari. You may give an answer.
Yeah.
Ibu Sri Karyati.
Mr. Jauhari. Mr. Ju. Oke. Kalau kita bicara tentang kesehatan, about healthy pregnancy, we didn't say about health program, but a lot of program. Ya, jadi ketika kita bicara tentang kehamilan, persalinan, itu kita tidak hanya bicara tentang kesehatan. Jadi seperti tadi disampaikan, angka kematian ibu masih tinggi. Kenapa masih belum bisa menurunkan sampai ke yang diharapkan? Itu karena yang mempengaruhi sangat banyak, multi program. Bukan hanya kesehatan saja. Kesehatan berjalan sendiri pasti akan tidak berhasil. Karena apa? Ya, faktor budaya itu sangat kuat sekali, termasuk termasuk kesadaran untuk melakukan asesmen premarital, melakukan screening check up premarital, screening check up, premarital counseling, sebab seringkali pernikahan itu dianggap sebagai sesuatu hal yang alamiah. Ya, benar alamiah. Tapi ketika sesuatu hal yang alamiah itu tidak dibarengi dengan pengetahuan yang cukup, itu bisa menjadi permasalahan yang sangat pelik di kemudian hari. Bahkan meskipun itu dibarengi dengan awalnya itu adalah saling cinta, apalagi ketika pernikahannya itu bukan didasari oleh cinta, itu semakin besar sekali permasalahan yang yang akan dihadapi. Jadi untuk meningkatkan cakupan biar di kemudian hari kepedulian untuk melakukan persiapan pranikah, baik itu persiapan untuk konseling maupun persiapan untuk screening check up, maka di sini perlu sosialisasi yang masif, bukan hanya oleh bagian kesehatan saja, tetapi kita bisa menggunakan key person. Ya, kita ketahui bahwa di budaya kita orang-orang Indonesia di budaya kita itu seringkali ada key person yang lebih dipercaya daripada orang kesehatan. Jadi di sini tadi saya sampaikan bahwa untuk kelas pranikah itu sekarang sudah banyak sekali yang yang dibuka oleh badan-badan agama tertentu, baik dari Islam, Kristen, Hindu, Buddha, Katolik gitu ya, itu semuanya ada. Jadi di sini tokoh agama, tokoh masyarakat itu juga digalakkan. Sampai saat ini sudah ada konseling pranikah di Indonesia, tetapi memang pelaksanaannya belum optimal, dan kesadaran para calon pengantin pun biasanya ya kecenderungannya masih sangat rendah, padahal manfaatnya itu sangat luar biasa. Gitu Pak Safik, terima kasih.
Okay, so that's the wonderful explanations. It's really clear and detailed. Baik, so to those who ask, Pak Jauhari, mudah-mudahan sudah terjawab pertanyaannya. Is there any another questions? Masih ada? We still? Oh, maybe one last questions. Coming from Ibu Islami, the question is, how to increase the awareness of couple to do premarital screening?
Okay. Budaya kita memang masih belum belum terbiasa dengan adanya premarital screening check up. Mungkin dianggapnya adalah, aduh, nanti kalau ketahuan nanti tidak jadi menikah, jadi ketahuan nanti ada sakit ini, nanti tidak jadi dan lain sebagainya. Premarital screening check up itu bukan untuk menghalangi pernikahan, tetapi untuk mempersiapkan supaya dalam pernikahan itu akan ada saling keterbukaan, dan bersama-sama pasangan itu akan melakukan suatu upaya supaya ketika ditemukan ada suatu penyakit atau genetik yang bisa berisiko terjadinya penyakit pada keturunannya, itu mereka memiliki kesiapan, ya, sehingga kesehatan pada keluarganya di masa depan itu lebih penting daripada kehidupan hanya saat ini saja. Caranya ya pertama adalah sosialisasi, peningkatan pengetahuan masyarakat terkait pentingnya untuk premarital screening check up. Ya, dengan melibatkan banyak pihak, banyak faktor. Problem yang kedua untuk premarital screening check up juga memang membutuhkan biaya yang cukup tinggi, sehingga untuk masyarakat kalangan menengah ke bawah seringkali menganggap bahwa itu benar-benar tidak penting. Jadi seperti kita ketahui ketika kita kasih pemetaan gitu ya, beberapa penyakit keturunan hereditary disease itu adalah mengelompok di suatu tempat. Semisal thalassemia disease. Thalassemia disease itu ada kelainan pada sel darah merahnya yang itu ada hubungan dengan genetik yang dibawa. Ketika bapak atau ibunya itu memiliki gen resesif pembawa, itu dia tidak akan kelihatan. Ya, dia tidak akan kelihatan. Tetapi ketika resesif itu bertemu, jadi kedua-duanya itu resesif, Mendel ya, hukum Mendel diingat, itu akan menyebabkan anaknya nanti itu adalah, ya kalau ibu resesif, bapak resesif, kemungkinannya adalah 25% anak akan mengalami talasemi mayor, 50% akan menjadi pembawa, dan 25% akan sehat. Nah, ini akan harus didiskusikan, karena apa? Ketika next time mereka punya anak, terus kemudian mendapati kejadian seperti itu, ternyata salah satu anaknya adalah yang 25% mengalami talasemi. Itu mereka sudah siap, tidak saling menyalahkan. Jadi itu salah satu pentingnya. Jadi biasanya untuk saat ini itu belum membudaya secara luas, tetapi untuk premarital screening check up itu biasanya pada daerah-daerah tertentu yang di situ adalah endemik untuk permasalahan penyakit keturunan, seperti itu. Jadi sosialisasi ke masyarakat itu memang harus lebih intens supaya kedepannya itu kesadaran untuk yuk kita melakukan screening check up, bukan karena apa-apa tetapi untuk kesiapan. Apalagi di Indonesia misalnya untuk penyakit menular ya, infection disease like HIV itu sampai saat ini yang mau open, yang mau menjelaskan, yang mau terbuka bahwa dia itu adalah menderita HIV itu masih sangat kecil sekali di Indonesia, karena masih adanya ya nanti dikucilkan, nanti dibilang begini, bilang begitu gitu ya. Padahal tidak semua pasien HIV itu karena pergaulan bebas, bisa jadi karena kecelakaan gitu ya. Terus ketika ketahuan salah satu, maka apakah pernikahan harus digagalkan? Tidak selalu kan. Banyak kok teman-teman yang HIV kemudian menikah dengan yang tidak HIV dengan persiapan, dengan kesadaran yang penuh, itu menjaga pasangan dan bahkan mereka memiliki anak yang tidak menderita HIV. Tapi dibayangkan kalau misalnya tanpa screening check up, pasangan tidak tahu kalau pasangannya itu adalah menderita HIV, maka biasa-biasa saja. Ya, tidak ada upaya pencegahan. Ini akan menyebabkan pasangan bisa tertular. Dan ketika hamil, terjadi kehamilan, itu juga tidak ada pencegahan supaya anaknya nanti terbebas atau dicegah supaya tidak terjadi penularan HIV dari ibu ke bayinya melalui transmisi darah ibu ke bayi, seperti itu.
Right, so that's,
Thank you.
yes, it's a very clear explanations from Guci Sri Karyati. Seems that we don't have any more questions. Sudah tidak ada pertanyaan lagi, nggih? Okay, so yeah, it seems really interesting for these discussions today. And before I close this last session, I need Ibu Sri Karyati give a closing statement, please.
Oh, closing statement. Okay. Parenting complication, preventing complication of pregnancy and childbirth can be done only after pregnancy has occurred. This should be done before conception or preconception, even should be prepared before the marriage. Premarital screening, check-up, and counseling period provide adequate knowledge to couple so that they can build a happy household, and when pregnancy occurs, this pregnancy is well planned and cared for. So they will protect the pregnancy from a lot of complications, and mother and baby will get healthy, and yeah, MMR will be decreased. Okay, thank you, Mr.
Thank you very much, Ibu Sri Karyati, for the wonderful presentation and closing statement. Yes, with the end of Ibu Sri Karyati's presentations, so this is the last sessions that we have for the first international webinar on nursing series today. And let me say thank you once again to Ibu Sri Karyati. So have a nice day and see you for the next presentation. Right, well, ladies and gentlemen, so yeah, right, yeah, well, ladies and gentlemen, I'd like to say thank you very much for your nice participations for today's webinar. Now we still have about 160 participants joining for this conference. I'd like to say thank you once again for today's international webinar series on nursing. And don't forget, so we still have another international webinar series, so don't miss it. Jangan dilewatkan. And last but not least, I'd like to say thank you once again to dear participant. And my name is Shafiq. I'd like to say sorry if I have a mistake when delivering when guiding this webinar. So thank you very much. That's all from me. Assalamualaikum warahmatullahi wabarakatuh.